Rutland Health and Wellbeing Board, and to members of the public who are listening in via the Zoom webcast. We have another busy agenda for today's meeting, so firstly to practical matters. I'd like to remind members of the board to please raise their hand if they wish to speak and to ensure that their microphone is switched on when addressing an item for the benefit of the recording and muted when not. I'll refer to Jane from governance if I need to record a vote or any procedural matters. Thank you. So moving first to apologies. Jane, have we apologies?
Yes, Chair, we have received apologies from Dr. James Burden, from Inspector Lindsay Booth, from Louise Platt, Mark Powell, Mel Thwaites, but we have representatives. We have Sarah Premer representing Auntie Williams, and we have David Williams listening in on the meeting.
Thank you, Chair. I do note that we have Mel Thwaites and David Williams on Zoom. They can view but are unable to take part as panellists due to the government restrictions on hybrid meetings. Members in the room and those watching on Zoom will see that we do have some officers who are allowed to be part of panellists. So officers of the board are allowed to take part via Zoom, but members of the board are not. Thank you. Is that clear? John's looking not clear at me. Very clear. So we'll move to item 2 on the agenda. That's my statement. So the pace of change in the world around us is considerable, and it's clear we will all need to be agile and resilient over the coming months. We're meeting today just 12 days after the launch of Leicestershire and Rutland's Integrated Care Board, headed up by Andy Williams. This is the successor body to the CCGs, and we wish them every success in their lead role to ensure the availability and quality of health services for 1 million people across LLR, working with partners, including all of us around the table. The Integrated Care Partnership, here called the LLR Health and Wellbeing Partnership, is a new system-level governance group that will help to inform, steer, assure and coordinate developments and support ongoing coherence and synergies between system and place. Some of you joined the development session held at Leicestershire County Council on the 30th of June, where stakeholders from the ICB and the 3 LLR Health and Wellbeing Boards reviewed our shared priorities and how we can work together most effectively. Local people will be pleased to hear that access to services was a prominent shared priority to come out of that discussion. You'll also be aware that there have also been some changes at the council since our last meeting. The council's new leader, Lucy Stevenson, now presides over an alliance cabinet made up of Conservatives, Independents and Greens. She has launched a council leaders blog, the links attached, on the council's website to enrich the dialogue and with local stakeholders and the public. I am proud to have been invited to continue to serve in her cabinet as portfolio holder for health, wellbeing and adult care, alongside Councillor Wilby, who retains the portfolio for education and children's services, and to be able to continue to lead the important work of this board. I'd also like to welcome Ian Crowe, our Armed Forces rep, to the board. This is his first meeting. The Council's new 5-year corporate strategy was approved by Council on the 4th of July. This was informed by the Future Rutland Conversation and is also closely aligned with and supports our joint health and wellbeing strategy. I will share links to this on the Council's website so that you can take a closer look. The Council has also launched an issues and options consultations, which runs until the 16th of September on the new 15-year local plan, and is the first of 3 consultations in this planning process. The current consultation is focused around how we should tackle 12 important planning issues, a number of which impact directly on health and wellbeing. I will share a link. Do take a look and share your views. Other open consultations or engagements health and wellbeing members and the public are invited to take part in are listed on the Rutland Information Service on the page Get Involved, Have Your Say. Notably, they are the end of life service needs in Rutland and Leicestershire, which is closing tomorrow. The 2 open until the 22nd of July are the LLR Draft Carers Strategy and the National Approach to Special Education Needs and Disability. And another closing on the 6th of August is the draft pharmaceutical needs assessments, which is on the agenda, which of course we are discussing. In our communities, COVID rates are rising again, estimated at 1 in 25 people across England in weekend in the 29th of June. And this is translating through into some increase to outbreaks in care homes and also rising numbers of people in hospital with COVID, although the majority of these patients are in hospital for other primary reasons. Intensive care high dependency unit patient rates remain low at the moment, as do deaths. A cautious approach is recommended at this time. Some health settings have recently reintroduced mask wearing, and in social care, the COVID-19 supplement remains in place, guiding on infection prevention and control, including the appropriate use of PPE. More pressing now for most of our population are the spiralling living costs that are highlighted in my last statement, with price rises far outstripping any growth in incomes and hardships affecting a wider range of people. Fuel prices in particular are affecting both life at home, where we expect they will really bite this winter, and the ability to travel, including to work and school. There are no easy answers. The important thing now is to ensure, while we look further ahead in trying to tackle these issues, that people know where they can turn if their financial stability is deteriorating. Citizens Advice Rutland, working alongside the Food Bank, are an important partner with the Council in this, running the Council's Crisis Fund and providing vital information and advice. Over the last 12 months, CAR have helped to make gains of 1.7 million in benefits or debt write-offs for local people, a tremendous contribution to local wellbeing. After the pandemic, it is heartening to see Rutland's towns and communities gradually returning to normal life, with the summer marked by traditional town and village feasts and fetes, school sports days and proms, as well as other large-scale events that speak to our collective identity. The county show resumed on the 6th of June, putting Rutland's rural and farming community front and centre. Then Rutland's first Pride event was held in Oakham on the 27th of June, a celebration of our diversity with hopefully many more to come. Bird Fair in turn returns to Rutland this weekend in the new guise of the Global Bird Fair after a 2-year gap, this time at our showground. As one of the premier international not-for-profit conservation events, it reminds us of further pressing concerns we must tackle as a society. As we embark together on delivery of our health and wellbeing strategy for Rutland, and we will be talking about this more later, it's welcome that the census data sets have started to be released, supporting the refresh of our joint strategic needs assessment, which underpins all our work here. The demographic update confirms that our population has grown by nearly 10% over the last decade to 41,000. That's faster than the growth rate for England and the East Midlands. Rutland's population remains one of the most sparse in the East Midlands, but it's also ageing faster than in most places. The growth in over 65s of more than 30%, while working age population is growing at a slower rate. This brings us back to the importance of our work in ensuring that health and wellbeing services meet the needs of our changing population, including through prevention and postponement of ill health. I've attached a series of links for everyone for all of those things if they'd like to. It will be attached to the minutes. Thank you. Right, next we are also coming to the election of a vice chair. Now, we do need a vice chair for the board. Unfortunately, there is some criteria, so they can't be related to or employed by RCC. So I'm wondering whether we have any nominations for vice chair at all. Deb.
Thank you. So I'd like to nominate our newly appointed clinical lead for Rutland as a place, Dr. James Burden. He's a local GP and he's also the clinical director for the PCN. And we're really keen to make sure that we integrate health fully into the agenda of the Health and Wellbeing Board and that we get that partnership working right. So I think it will give the right message, hopefully, to the population of Rutland. Thank you.
Thanks very much, Deb. I would second that nomination. Do we have any other nominations at all? No. Now, this is where we confess we haven't actually spoken to James about this. And he's not here to say no, because he's on holiday. However, now I am aware that we did say last time when we did our work plan that we would have some meetings online, but obviously our decisions have to be made in person. So I recommend that we, as a board, kind of accept James' nomination if you're agreed, but obviously on the proviso that he would be happy to take up the position. So it might be something we need to revisit, but I would propose that we pass the nomination and hope that he is agreeable to it, and that if not, then we defer it back to the next. So if the rest of the board is happy with that, then we can vote. Jane, are we able to?
Need a vote.
We do need a vote for it. So I would propose that James Burden is appointed as vice chair with his permission after a conversation. Do I have a seconder for that? John would second it. Thank you, Deb. And then are we all in agreement? Yep, that's unanimous. Thank you very much, everyone. We hope that James is happy to take on. We'll confirm to the board if that's not. Thank you. So agenda item 3 is the record of meeting. It's to confirm the minutes of the last Health and Wellbeing Board on the 5th of April. I'll propose them. Can I have a seconder, please? Thanks, Deb. Alton, thank you. And sorry, first should have asked, was there any comments or that anyone had on them? I didn't believe there were any, but no, everyone's happy. So sorry, I'll propose. Deborah has seconded. All those in favour to accepting the minutes. Thank you. That's unanimous. Thank you, Jane. So agenda item 4 is actions arising. There was only one action arising from that last meeting, and that will be picked up in the agenda item. I'm right in thinking that, aren't I? Where did I put it? That is, yeah. And that was just Deborah and Sandra were picking it up with regard to the delivery plan. So we'll pick that up in. So we move on to agenda number 5, which is declarations of interest. Do I have any interests in any of the declared items? No, thank you. And agenda item 6 is petitions, deputations and questions. Jane, have we received any petitions, deputations or questions?
Yes, Chair, we have received one deputation from Mrs. Jennifer Fenelon on behalf of the Rutland Health and Social Care Policy Consortium. The deputation has been approved by the Chief Executive and the Monitoring Officer and has been added to the website and circulated to committee members in advance of the meeting. As per Procedure Rule 73, the total time allowed for presenting a deputation is 5 minutes, and committee members may ask questions of the members of the deputation for a further period of not more than 5 minutes. These questions shall be asked and must be answered without discussion. I shall now ask Mrs. Fenelon to approach the table and please read out her deputation.
Good afternoon, Mrs. Fenelon. Please read out your deputation. You have a total time of 5 minutes. Thank you.
Expected, so I may shave a bit soft and I may talk fairly fast. If I'm too fast, can people stop? Stop. Can you hear me? The policy consortium recognises the huge amount of work that's being done and the progress that's been made today, and we want to build on that and that progress with our comments. The strategy was approved at the last meeting in February, and our consortium supports its objectives. The next steps are to ensure that these objectives are delivered through a comprehensive implementation plan and to take the public with them, both in the development and its implementation. Challenges need to be identified and solutions developed. And this requires an assessment of where we are now, where we want to get to, and how we should get there. And Rutland citizens should be involved in that process. The implementation plan, the green one, which I think it's the green one, which is actually a list of 104 actions, and action lists on their own don't make for implementation. The Rutland Health Plan needs to integrate with other operational plans for local transport, UHL reconfiguration, and local and corporate plans. This is a complex challenge, and it needs to be resolved by, in the jargon, smart planning tools and comprehensive project management approach. And we're anxious that that happens. The material presented to this meeting could have been presented more succinctly. To be honest, there's a lot of paper there, and some of us took 2 or 3 days just to read it. Additionally, a communications and engagement plan is on the agenda, and it will be hard to get meaningful commitment and understanding from the public unless the plan is presented more simply and with clarity about its aims. We make, in the spirit of collaboration, 9 recommendations, and I'll go through them very quickly. They're on the website. And the first is that there should be an executive summary. The plan is very long and it's very dense with a great deal of jargon. We distinguish between things that are produced for internal use, but it needs to be clear and a comprehensive summary produced. The plans need to clearly support the objectives, and many of our consortium colleagues have extensive experience of implementing complex plans, but we feel that the evidence shows that there must be agreed and ring-fenced resources and budgets for delivery, and that there should be a thought out and clear process with milestones which are smart, specific, measurable, achievable, realistic, and time bound. 3, there needs to be clear responsibility for delivery of the overall health plan. Many parties are contributing to the plans with concurrent timescales, but these are not obviously integrated. Their implementation needs to be coordinated to reduce risk and duplication. Interdependencies should be identified and an assessment of risks included. Any plan that's dealing with high risk stuff like COVID-induced backlog, UHL reconfiguration, major financial challenges and other high risk activities must recognise their interdependencies and plan to address them in a proactive way. 5, the relationship between the various plans should be clearly explained. We know that medical care alone impacts about 20% of someone's lifetime health and well-being. There are many other determinants of health, including education, housing, employment, and environment, as well as personal characteristics. The health plan should recognise this wider context. There are then specific things relating to Rutland, which we know sufficient resources and Rutland's specific needs as an isolated and rural community. I would just focus on Rutland Memorial Hospital. Determining the future of this hospital is important to fulfil the objective of bringing care closer to home. Its content needs to be defined rapidly with Rutland people. And Stamford Hospital is a useful model to follow. Linking the hospital development with primary and community care provision will be seen as a very positive outcome for Rutland. The consortium recognise that determining their future is complex, but we feel that it must
1 minute remaining.
be done. And lastly, the public engagement plan is on this agenda today, and we would like to see Health Watch and the Council developing regular two-way communication with the public. Those are our recommendations. The consortium offers this in the spirit of supporting the work that you're doing, and we offer our assistance. Thank you very much.
Thank you very much, Mrs. Fellman, for your deputation. We will, do we have any, sorry, I'll put my head on. Because this is deputation and not questions, we don't give a verbal or written reply. However, members of the board can ask questions, and we have 5 minutes, I think.
Yes, Chair, total of 5 minutes.
Total of 5 minutes. So if any members want to ask any questions to speak to the deputation, they're more than welcome. Mike. Yes.
Yeah, thank you, Chair. I'm trying to put it as a question which I can ask you rather than an answer which I can't. But I'll say the point and then you can help me with a question, because I think if I can get around it. The only thought in my mind is, I mean, I also welcome the feedback and I think it is great. And you're right, we would always strive to get to smart objectives. Part of me would say we're in a sort of betwixt and between bit where some of us have, you know, we've set out what we want to achieve, and yet the moving parts of what is an ICS, what does it do, what do we do as a health and wellbeing board aren't quite resolved. So I don't quite feel, and it's not to say we're not going to do it, that we're quite at the stage of being able to say we will do this in this way to achieve that, because there's other stuff like the relationship between different strategies, you know, like the relationship between different strategies, like the relationship with other bodies that we need to work out. So if there's a question, it's
can we just check the sound, because I'm wondering whether these are very loud. Can you hear, Miles? Paul, can you hear? Not... Can we turn the speakers up? Sorry, we'll just bear with us while we just turn the speakers up just slightly, because if Miles and Paul can't hear either.
do I just need to come closer?
I do think,
yeah,
when we were in cabinet this morning, the actual speakers weren't very loud, so I think we just need to turn our volume up a little bit. If everyone bears with us just for 2 minutes, and then hopefully we'll hear when it goes up, and you'll be able to say over there if you can hear us. Yes. Don't know whether that is that any better? Oh, that's better, isn't it? Thank you, Jane. Yes, that is better.
right. Shall I go for it then?
Yes, go for it.
How's
Please.
that better? Right. So I'll summarize where I was if you didn't catch it, which is that one, which is totally get the points, really valid feedback. Not quite certain if we're at the stage we can really set smart objectives for everything, if only because so many of the moving parts around what's the role of the integrated care board, how do we fit as a place in that system, are not fully resolved yet. So I'm wondering if there is a question, it's kind of almost picking your brains, asking your advice about how do we get from the high level strategy which we've set out to the point of having the smart objectives. And I'm almost wondering, is there such a thing as a thing between an implementation plan and a high level strategy? If that makes any kind of sense. I'm trying not to confuse things by going, we can never do smart objectives because it's like knitting fog, whilst accepting we need to knit a bit of fog at the moment before we get there. And I'll pose it as a question as what could get us between there and there? And I'll leave it
We
at that.
think there are things that you need to do before you start setting your final objectives. Let me give you an example, a concrete example. If you look at page 77, item 4, access, and we know that access is a huge issue in Rutland. The very first item is undertake an out of area contract review for LLR commissioned services. Now we know that more than half the services, reputed as 77%, goes as far as into Peterborough. And if we haven't started that work, you're going to end up with the wrong answers. So I think we're saying, get a sequence sorted out. There are things that you need to do first before you reach the conclusion. And we're really worried that the conclusions, conclusions are being reached without that work being done. Could you excuse me while I get my glass of water?
No, thank you. That's really useful.
Did anyone else have any questions for Mr. Fenlon?
I just wondered if that made sense. There are more examples on that page about work that has to be done before you start. It's about working out what the need is. Where are we now? Where do we want to get to in a sequence? And we're not seeing that sequence coming
Yeah,
through.
no, I think that's really useful
Does
because
that make
that's the bit. It's like, yeah, I know. Yeah, we can't do the smart work yet, but nor do I want to leave it as the knitting fog bit. So it's almost describing the step in between.
Yeah, it's like
And if that's the step in between that we can then come back to the board and go, it's almost progress towards getting from a broad strategy to a defined implementation
What
plan. If that's what you're
system.
looking for, then I think that's
don't
quite a
put the
useful way
roof
to
on
describe it.
before you build the foundations. I think.
Thank you. John, would you like to come in?
1 minute remaining. Sorry, John.
It'll be quick, and thank you, Mrs. Fenn, and that broadly agree with everything that you've just said there. Interested in your point on co-production, because that's certainly an issue in the council that we've been thinking about, and linking that with Mike and your own points about having this bit in the middle that joins up. Do you think if we was to have some dedicated resource within the council, some officer time to actually focus on some co-production and to focus on understanding where these gaps are, that would help, because we might have some capacity to do that.
Our colleagues from Health Watch should be able to comment better on that than I would. But I think you do need resources. It's very labour intensive going out and working with people, but it pays dividends in the end because people are committed to the outcome and they understand it. They understand what you're trying to do. I was involved in. Good. Now I'm losing my voice. Sorry.
Thank you, Ms. Fenlon. It is time. Thank you very much for your for the deputation. Please return to your seat. And I would like to reiterate that we'll continue to work in close collaboration with stakeholders as part of the integrated delivery board to ensure that the voice of our residents is heard in such matters. So thank you. We're now on item 7. Which is questions we've noticed from members. Chair, do we have any questions with notes from members?
None received, Chair.
Thank you. And item 8 is notices of motion from members. Chair, do we have Chair? Do we have any notices with motion from members? That will be a no. Do we have any?
Sorry, Chair.
That's all right. I'm calling myself Chair.
No notices received, Chair.
Thank you, Jane. Item 9 is the Leicester and Rutland Integrated Care System update. It's a presentation from Sarah Prima. So Sarah, over to you, please.
Thank you. So I just wanted to give you a bit of an update about where we are in relation to the integrated care system. And I think Councillor Harvey referenced it in her opening remarks, actually. So the 1st of July was the go live date. We had our inaugural meeting. So effectively just before midnight on the 1st of July, well, the 30th of June, the CCGs closed and the ICB, the Integrated Care Board, came into existence from the 1st of July. There was an initial inaugural meeting on the 1st of July, which concentrated on the governance, accepting governance arrangements, etc., and setting up the organisation as a legal entity. All members of the Integrated Care Board have now been appointed and are in place, and the board consists of executive officers of the Integrated Care Board, independent chair, non-executive directors, partner members from our provider trust UHL LPT, and then partner members from our local authorities, including Rutland, and also a clinical and GP member to the board. Obviously the next big task for the ICB, in particular in terms of the changes that were enacted as part of the Health and Social Care Act, is the work to assume the direct commissioning and specialised commissioning work that NHSE currently undertake into the Integrated Care Board, and we will take delegated responsibility on for both direct commissioning, which is pharmacy, optometry and dental, and for some specialised commissioning lines from the 1st of April 23. So our transition work now focuses on that piece of work. The other thing I will just touch base on, and again Councillor Harvey spoke about it in her address, was the Integrated Care Partnership, which locally we're calling the Health and Wellbeing Partnership discussion that took place a couple of weeks ago, which was focused on, it brought the 3 health and wellbeing boards together across LLR, was focused on what did we want to do as a board and how did we want to make a big difference. And we talked a lot about what could we do, what were the right things to do at a system level as opposed to duplicating the work of health and wellbeing boards and place. So that was a really good discussion actually, and we got lots of ideas out of that. And the next stage in developing that process will be for the inaugural meeting of the Health and Wellbeing Partnership to consider the output from that event and endorse the priority areas that were identified that day. And then we spoke about and to endorse an approach, and on the day we spoke about an approach that was workshop type arrangements for key areas that we decide to work on. And you know, a couple of the things that came out that day was access, and also around the cost of living crisis, for example, and also how as public sector organisations we can support that anchor approach across LLR. So I think that's the key highlights from the ICB. We made it and we're now in existence. It's been my life for the last 18 months, the transition. So it was a sigh of relief when we got over that midnight line. Thank you.
Thank you, Sarah, and I'll say congratulations for getting over the line. We do appreciate all the work that partners in the CCGs have done. We know you've been working around the clock on a very short time frame in a pandemic to get this across. It was not the best timing, we should say. I'd also reiterate your remarks about the partnership meeting that we had, that workshop. I don't know whether fellow members around the board who took part, it was a really great day actually, and I felt that the workshop element to it was fantastic and we got lots and lots out of it. Is there any comments, sorry, from members? I think Mike just stuck his finger up just before you. Oh, so Dr. Underwood.
Yeah, thank you, Sarah. And can I add my congratulations and my thanks, because I know you've worked really, really hard. And it's been great that you've actually involved so many people in all these deliberations and listened to what people are saying. So really appreciate that. And likewise, I found the Health and Wellbeing Partnership meeting excellent. It was really good. And I was really pleased that the two main issues seem to be access and cost of living, which affects everybody out here in Rutland. My question is, and it's something that I've raised with both Sam and yourself and with Andy Williams, is how long is this core partnership going to last before extending the membership to actually include wider stakeholders and also representatives of the public voice? I think it's really, really imperative that the public are involved in it. And that was actually another key issue that came forward at the partnership meeting.
So I think we need to get to that first inaugural meeting and then it gets discussed there, I think, because what will go there is the terms of reference for the group. And I think we can then at that point discuss membership. I mean, I think the thinking is at the moment, and is that we will have a bit of a, we will have some formal meetings and then some of the workshop type meetings, because I think that really did work. So when, you know, if we wanted to, for example, discuss what actions we could take around the cost of living crisis, I think that would work much better as a workshop. But we need the formal meetings because you do have to meet in public. So I think we'll do that as part of the inaugural setup of the meeting, Janet.
Thank you.
And we will report back as soon as we'll report back, make sure it's on the agenda for the next board for us to report back. If I'm sure that we will have met as the partnership by then. Because I think there was something going in the diary this month. I think it's not hit my diaries yet, which is why I'm looking slightly blank, but I think it is. So I will chase that. If we put that up as an action for me next week, I will chase up and I will hopefully then get that out with the minutes of the meeting so that partners are aware when we are actually meeting. I don't know whether you've had any.
So I've asked for our governance team to start to look for a date.
Oh,
okay, so
excellent.
it might be August, but with it now being in July, but I have asked them to look for a date that people can do.
Thank you, Sarah. So we will, as soon as that, I will make sure that's appended to the minutes. Thank you. Sorry, Mike, you were next.
Actually, the time's passed, but there's a couple of comments just to agree with Janet. I think going into the initial meeting of the Health and Wellbeing Partnership, there was probably for a number of us a sense of what does this add different than what we're already doing at this, venues, forums like this? Whereas actually there was something there about those issues. And I think the other bit, as well as the issues around cost of living crisis and access, for me, it was about that making sense of the phrase anchor institutions, which I've kind of struggled really to understand what it means. But if it's about how collectively across LLR make a difference to some of these hot topics, key issues that are in the news, then actually that was a really worthwhile conversation. And again, I don't want to, we need to have that conversation as lead member, but in terms of the bit about membership, I think the way we worked on that day is probably indicative of where we want to get to. So there probably has to be a tight steering group or formal partnership, but I just don't see that collectively, us two, the lead members for City and Leicestershire, the DPH for City and David and Andy can realistically, we can plot and plan, but the doing work really is about drawing in other people. And actually that was a really good example of how it worked on the Thursday. Yeah,
I concur. And just to reassure the wider members of the board who weren't there. So with the chairs of the other health and wellbeing boards, with David Seisling as chair of the ICB and with Andy Williams, we'd had an initial meeting, and it was really about the housekeeping of how to have a meeting with 3 huge, quite big health and wellbeing boards, and how in a 2-hour meeting, how that would then be meaningful. And it is a real conundrum. So the tight group came out of the fact that in the development stage, the housekeeping, it was easier to manage and to have those discussions. The workshop was a great show of how well we can all work together as a wider group, but be more focused. And I completely agree, that Janet, that actually the public voice is essential in it all, not only as a public meeting, but also as part of that kind of membership. It is really about just, and as Sarah says, this next meeting, I think, will just kind of confirm who the tight membership will be, and then how we go about just with the housekeeping of allowing all different parts of the boards to have their say. Sorry, Dawn, if you'd like to come in.
Thank you, Chair. And just to add to that and support what Janet, you were saying about kind of representation of our communities. I mean, you would expect me to say this as Director of Children's Services, but the voice of children and young people are absolutely vital. This is not about just the adults in the health system. It is about our children and young people, and clearly there is priorities within our strategy around children and young people, but equally it's brand new. So let's just, let's do it properly, because what's worse is actually if we try to run before we can walk, actually, particularly from a children and people's point of view, it'll put the, it kind of can put them off, and so it's getting it right as well, and meaningful participation, not just tokenism, because I think that's so easy. So I'd rather us take our time to really engage, think about how we engage properly, and work with young people about how they want to engage, etc., and get it right, than quickly move to something that can be seen as tokenism. So but fully supportive of the way forward.
you won't be surprised that I would agree with that level of participation. And I can reassure you that I was actually speaking, sat next to your counterpart from Leicestershire during that workshop, and she was very forward in the views for the children. So fear not, she was a great advocate for all children in the sector. Are there any other questions or comments on this section? Nope, I shall move on then. That was that we didn't have to take a vote. That was just for noting, wasn't it?
Yes.
So we are now on to agenda item 10, which is the joint health and wellbeing strategy place-led delivery plan. So I think this is over to Sandra Taylor to give us the rundown. Thank you.
Thank you very much. So obviously we've already been talking about the joint health and wellbeing strategy today, and we've been talking about this and working on this for quite a while now, and it's been quite a journey. And I just want to remind long-standing members will remember our previous health and wellbeing strategies, and they were on a different scale. I would say they were much simpler, lighter documents, and in effect what we were agreeing to do was all swim in broadly the same direction. And that worked very well. But the plans which we're working on now and the new system that we're within is more like synchronized swimming. You know, there's a tremendous ask on everyone, but the outcomes that can come from that are potentially greater. So we are very much engaged in a journey where everyone is in a sort of a learning process. We've got a significant turnover of personnel, changed organizations, people are getting to know each other and their possibilities, and trying to squeeze as much as we possibly can out of budgets that are already fixed, because remember, there's no new money necessarily coming into this program. So it's about really a tremendous amount of creativity, understanding, collaborative working, and I just want to sort of set that as the context for because you end up with a set of rather dry papers, but actually what's happening behind the scenes is people working together purposefully on things that they've been working through and understanding for a period of months through the strategy, which we didn't represent to you. And then that's now coming out into a work program. And what I am actually proud to say is that we haven't been sort of standing on the edge of this, afraid to jump into the water. In fact, people have already been working together, and we have some very substantial products coming out of the first couple of months of work, even before we've reached the point today, which we talked about as the launch of the strategy. So I just want to highlight within the paper, I've highlighted a couple. Mrs. Fenelon talked about the need to have that process of sequence, and she's absolutely right. So, for example, the health inequities report, to really get deep into understanding that question, that is well advanced at this stage. We also have a report well underway, which is about end-of-life care, where again, we realised that around the table, we didn't necessarily have that depth of understanding. We've also been putting some key enablers into place. And again, I'd like to just highlight a couple. One would be the social prescribing platform, which we're putting into place, which will span across our voluntary sector and into our own services, and actually gives us that infrastructure that means that people can cooperate and collaborate in a way that they never could before. So that's a step change for us. Also, I'd highlight the shared care record, which is on its way, because we know that some of our achievements have been held back by that inability to share information. So tremendously important bricks being built into that foundation. Quick wins as well. I think, again, I just want to highlight a couple. The PCN in particular have been successful in promoting a program whereby they are recruiting additional pharmacists, and they'll be qualifying them through a University of Nottingham scheme so that they can diagnose and they can prescribe, and they can diagnose and prescribe. And that really will be buying them a tremendous amount of flexibility that we have been crying out for a very long time. So all sorts of exciting ideas coming forward, and things which will be making changes for real people in our communities, you know, sooner rather than later. So I know that you've received a lot of reports across the activity. So I did just want to talk about the reports just very briefly. And obviously our context is also characterised by the conversation that Mrs. Fenelon and Mike had just had about our pieces gradually coming into place. So there were a couple of reports for you today. One of them was a summary. So there's a slide deck which seeks to summarise across the priorities what the progress has been over the last quarter and what the plans are for the next quarter. And I'm very interested, we are all feeling our way. I'm very interested in whether this report is the type of thing which supports you in fairly rapidly getting a sense of what's going on in those priorities and why, and how we can potentially build on this to make this even more useful for you and also for those implementing the programme as we go forward. You also have received an update on indicators, and that's standalone at the moment. And I think one of our next tasks is to think about how we can integrate that more fully so that it's clearer to everyone how those documents relate together. And then thirdly has been the delivery plan. And thank you, Jennifer, Mrs. Fenelon, because I hadn't actually ever counted the actions. And we now know there are 104, and it is a substantial programme. It's a very ambitious programme. And it's a programme where what we're trying to do is not burden those who are implementing with too much bureaucracy. So we're trying to offer them a means to make their work visible and to update it light and simple to support the conversation and to be able to flag where there are issues or where there's good progress so that we can keep things light and we can focus people on the important work of delivering to the strategy. So I think that hope that gives you a bit of an overview. I would be very grateful if we could talk about the comms plan as maybe we talk about this first and then move on.
That's very much what I was planning to do, Sandra, don't worry. Just before I open up for questions on that, there's a couple of things as chair I'd seek the board's advice on. So the first thing is, do we like the high level summary reports as in Appendix A that gives us kind of a snapshot of where each part is, but also whether we feel as a board that gives us enough information for us to reassure ourselves that things within this quarter and the next quarter, we know where the work plan is in that short term, would be what I would seek to look for in that. So that we can keep a watch and provide guidance and steer mainly without getting bogged down. In asking that as well, I would bring in the comments between Mrs. Fenelon and Mike, because actually I think that does sit very much within this and may well influence us a bit more. But if we park that for now, the other question is, as a board, do we think the outcome summary, the one thing I did say, and it's more of a comment, but how I would question, how does the outcome summary report feed into the delivery plan? So I know there was a couple of outliners in the outcome summary report that don't look like they're reflected in the delivery plan, and I would wonder, I know there's one in there's a couple of points in children's, there's also a couple of points with regard to dementia and things, so I would wonder how we could as a board see that fitting together more broadly. Sandra, I will ask you just to clarify the RAG system for me, because obviously everything's quite a lot showing as green or grey, but obviously when you compare it to some of the other things, we might suggest that green might not be the right. So just a clarification on, as a board, where we're seeking that. So I think that was where I thought, obviously open to what others might think as well. So I'll open up. I don't know if Sandra, would you explain the RAG system first, and then I will open up to the board for comments, if that's okay.
Okay, so on the delivery plan, the RAG system is not measuring the state of the indicators, because then there would be a great deal more colour in there. It's measuring the progress of that action and whether we're on track, or whether we have the people implementing that given measure have concerns that they want to flag to either IDG or to the Health and Wellbeing Board. So greens mean that things are moving along nicely, or they're getting started, and there's nothing to flag at the moment. But there is probably an issue to work on, which might be rated at another scale.
Thank you, Sandra. So I would possibly add in then, are we happy with that reg rating as a board, or would we seek, I dare to say this because it will complicate matters, how would we then measure that against performance, so that as a board we're reassured? How would that interplay? That's my next question to the board as well. So I'll open up for comments, and I've probably confused everyone. Deborah.
Thanks, Chair. It's a really important question, and it's one certainly from a health perspective that we debate quite frequently, because actually both are important. I think the indicator and where we are against an indicator is absolutely important, because that's what we're all about. But we do need to recognise, and this Mike touched on this in response to Jennifer's report, that we're at the early stages, and the greens represented in this report reflect where we are against where we would expect to be at this stage of our process. And just reflecting on your comment about sequencing, I think it's really important and really, really valid. We balance that against not showing progress to the public and to the Health and Wellbeing Board on some areas that we know need to get done anyway, and they fit into overall strategies. So if I use health as the example, what we're trying to do as our part of our move into the ICB is develop our health plans as close to the population as possible. But there is recognising there are some things that we need to deliver system-wide. There are some things that we can deliver to a place level, and for us, obviously, that is Rutland. And there are some things that we would aim to deliver at integrated neighbourhood level. Now, because of Rutland's size, it's really important that and good that we have Rutland as a place in our ICB. But there are not as many opportunities to get that below at neighbourhood level. So we want to be able to reflect work that we're already doing, despite that important sequencing, but I absolutely recognise there are some areas as part of the health inequalities report work that we're not quite at the end point to decide our actions. It's an iterative process. So what I would propose, so it's a very long-winded comment, and what I would propose is that we try and develop a dual RAG rating, so that we have a RAG rate for where we are against where we would expect to be in our planning process, and then a RAG rating against the indicators, recognising that most of the indicators will be red at the start point, because that's the reason that we've identified the plans that we need to put in place, and that we would see, and it might not be in the first sort of couple of months those colours changing. It will be a change process, and then we can pick up some of the sequencing issues that have been raised. Does that help?
That does, Deborah. Yeah, what do other members feel on that? Janet?
Yeah, when I read all this, I actually thought, gosh, what a lot of work has actually gone on behind the scenes. So congratulations on that. You ask about whether I think this document is right. I don't think it is quite right, because I looked at it when I was reading, I was thinking, oh, and I was getting bleary-eyed with reading through it. There was such a lot on the screen. I think we need a much more simple public-facing document, probably in addition to this, with just the headline figures. This seems, I'm not an expert in these sort of documents, but to me this seems overcomplicated. And I don't know whether you need things like decisions not applicable, escalation not applicable, other risks. I think people want to just see their headline stuff, possibly, but I'm not an expert. It's just
Deborah, do you want to come back on that?
Yes, just can I ask a question of clarification? When you say more simple, do you mean more than this?
detailed one. This one I just found. Because I'm looking at the line.
I'm sorry,
Sorry.
can you just turn your microphones on? Thank you.
Sorry. You look at it from an iPad and it looks very complicated. The public aren't interested in a whole load of, they want something that's fairly relatively easy to read. As a board, we probably should be prepared for extra complexity, but I think Mrs. Fenelon's report actually pulled out the fact that it took her colleagues 3 days to read through everything. And I think I agree that it needs to be simplified a bit, if possible, but I don't know the governance around all that. And
this is the first time that we've drawn together what's the story on our programme, and that's involved a number of leads on those priorities, drawing that together. But this is absolutely open to grabs in terms of it has to work for everyone, doesn't it? And this is an absolutely open process. The escalation and decisions, I think those fields will come to be much more used as we find that once we're really at pace, then each of these groups, you would expect them to be saying, actually, I need the Health and Wellbeing Board's attention this time because my issue is, and that gives them that opportunity to make good use of governance in order to support them through the tough times, if you like. So some of these things might come in more useful later, but I mean, it could be that there's all sorts of things we could do on here to make it feel easier to kind of jump into it as a document, and absolutely open to that.
I feel a more simplified table embracing the whole lot with different columns in it, quite systematic, problem, what we've done, what we propose, where we've got, escalate or not. It seems a lot simpler to me, but
I think part of our challenge is that each of these areas is covering still quite a lot of work, isn't it? And but I think that the people who are leading on these priorities will also, you find over time you start to form a more of an accessible narrative about what you're doing, and it takes a couple of rounds for people to form that story about how things hang together. And I think that's part of the trick, isn't it? That this needs to tell a story about where we're going. And at the moment, it feels more like it's a lot of bricks, but are they making a house, or is it a barn, or is it what is it? And I think that's a journey that we're on. So all that feedback is incredibly welcome.
Mike, do you want to come in?
Yeah, thanks, Chair. Thanks, Sandra. So a couple of questions from me. So one of which is generally, should always try and simplify it if possible, as Janet was saying. But I'm looking at the colour coding and the RAG rating, and actually, they'll be green because they are preparatory actions. There's nothing particularly threatening them in them, if I was honest. They're the stuff that we have to do. So take health inequalities. We are looking at the JSNA health inequalities chapter. We're going to bring that to the October meeting, and therefore it's green at the moment because we're on course. I kind of get that. There's a couple of bits for me, one of which is, have we got a trajectory or the actions planned out for 3 or 4 quarters times? Because putting together the chapter, presenting the chapter is easy. The crunch one will be the conversation we have after that, which is now what we're going to do and what does that mean in terms of service delivery, changing resources, etc., etc. So I'd be interested to know sort of longitudinally whether we've got a plan that goes beyond the next quarter for all the objectives. And then the other bit, I think, is what Deborah was saying, is where does it fit with current performance? Because I can look at these actions and go, yeah, I'm happy with them, I agree them. And yet I'm not certain that members of the public would necessarily say everything is green with health and social care in Rutland. And I can't really have a strategy discussion which says we're all on track without having something that pulls in the kind of where are we now bit as well. And I suppose so there's 2 bits there, the longitudinal bit and then the kind of how does this then read across to current performance? And I know Viv's on the line. I don't know if she'd want to comment as well. So
Does Viv, here she appears as if by magic.
Yeah, thank you. And apologies if I'm hearing a repeat there. Yeah, thanks for the bringing me in on this, and thanks to Sandra for doing a lot of the legwork on this. Comments are really welcomed on this, and I think we can definitely take those forward and see how we do just make it that little bit more user-friendly and specific in terms of what we're trying to achieve. I suppose the thing for me that what we've got here at the moment is we've got a delivery plan which is showing our progress in terms of our outputs, so our tangible things that we're going to say deliver. So maybe that's a report, or maybe that's X people going to X service, or that sort of thing. So I think the delivery plan covers that bit. And then the outcomes report, or the performance report, covers the outcomes, so those longer term outcomes. And I think Deborah's point around having a RAG rating on two next to each other would hopefully bring those two together. So if we think around some of the indicators we've got around children's, there might be some indicators, I don't know, around, let's say, access to one of the newborn checks, for example. The indicator might be red at the moment in terms of because we're not hitting where we would want to be for that check, but actually the plans that we've got in place are getting us on there and on that journey. And we will also need to think around the data that we've got in that outcomes report has a lag. So depending on what indicator it is, it could have several months to a year lag in terms of where we are now, in terms of what our performance will be. So we would just need to bear that in mind in terms of those caveats. And the other thing I'd just like to raise is around, we do need to be aware around when we're looking at our outcome data, we need to be looking at trends, because Rutland, being that small geographical patch, will have a lot more fluctuations in terms of its data just because the numbers are smaller. So it's just bearing that in mind when we're sort of looking at the data. Just my final point was around simplicity, and we've talked a lot around making it more user-friendly, and I know there's discussions in the paper around that executive summary. I think what would be really good is around how we really strengthen what we're talking about in our communication plan. Maybe coming on to that in a second, but really bearing that in mind in terms of the way that we deliver these reports is a communication mechanism for our population. So if we can support that in any way forward, that's also supporting the communication plan. But I'll leave that there and say thank you very much.
Thanks very much, Viv. Any other comments? Sandra.
Just very briefly, something else we proposed in the paper, but we haven't talked about today, is that sometimes there are areas developing where actually we would be interested in seeing them in the round. And I think to complement the "is our programme on track, thanks," is actually being able to take themes and have a presentation brought, which really brings an aspect to life. We know that, for example, there's really exciting work going on in mental health developments, and rather than seeing that broken up into its constituent parts, let's have someone in the room to talk about what that really means in its whole. And I think that also will give us a really good complement, and over time we'll build into a sort of a mental map of something which is much more alive.
Thank you. Deborah.
Thanks, Sandra. And I'm glad you've drawn that out. So there are two things that I think it would perhaps be good for us to maybe bring to the next board meeting. One, a presentation around the changing landscape of primary care and how primary care services are delivered. So we're nationally moving away from a GP only led service, and there are a number of different professionals and the growth that in roles and some of those developments. And I've spoken to Dr. Burden about that previously, and he will be keen to explore that with the board and the public. And the second area is perhaps an update on our local diagnostic provision, and with some key pieces of work that are underway, that are developed that are discussed in the plan, that we can talk about progress. and then there is also some of the mental health plans. So obviously we need to plan the agenda appropriately, but I think getting some more of those live stories and updates, I think perhaps would be more helpful in communicating both to the board but also to the public some of that progress, rather than just a plan that has got some narrative in. But I'd welcome views. Thanks.
Thanks, Deborah. I was just going to say, Ian, did you have your hand up? Go. Janet.
Can I just add to Deborah's list, please, and say that I think what Rutland people want to hear about is more about care closer to home, not just the diagnostics, but care and treatments closer to home. I'm thinking particularly of one of the things that we picked up a lot of last year when we were doing the What Matters to You project was just a simple thing like people wanting to have their eye injections locally, and that's been ongoing for quite a while, and I know that it's in the plan, but there's nothing specific about it.
I think you'll find you've jumped ahead to agenda item 15, so I'm going to close you down, but hold that thought till agenda item 15, please. So we'll come back to your care close to home at agenda item 15. Thank you. Any other comments? No, right, I'm going to try and pull this together. It's not going to be easy. So what I think we've got to as a board, and I as chair, I don't know whether the board will agree with this. I'm thinking we might need to have a few dry runs of this to get get something together. So as chair, what I would suggest is we ask each of the priority leads to have a look through their sections. I agree with your dual RAG rating. I think that would be the way ahead so that we could see that. However, I think as with the provisos, I don't think we're going to see the benefit of that for a little while yet. But I wonder whether we could tweak these as the high level summaries and maybe simplify them slightly, bring in some of the comments Deborah said, maybe bring in something around Mrs. Fenelon's points as well, and whether we could maybe have something that meets in the middle and brings in your points as well, Janet. But what I recommend is if we ask the leads to update, if we give them a time period, I'm conscious that I'd probably like something more solid before we meet again in October, so that because otherwise this is just going to keep going on for the life of the plan until we get it right. I want to kind of hone it in a bit more. So if I'm thinking, do the leads think that a month, a kind of calendar month to get something, have their tweak is enough time? I'm looking around for the leads here. Do you think that's enough time for them something to be then sent around together? And then I'm wondering whether the board would be happy for me to maybe have like a little stakeholder thing. I'm hoping, I'm looking at you, the boss too, next to me, and I bring in obviously Janet, but also the Mrs. Fenelon and things, so that we can get a wider view about whether it's working and then report back. That gives us basically out to leads back together just to have a sense check, so to speak, on how we're all thinking, then back out to leads for comments, and then we bring a more finalized thing in October. So that's a 3 month. What do board members think on that? Do they think that's a suitable plan? Mike?
The 3 months, yeah. I'm just worried about the next month because of course everybody's on leave because the schools are broken up. But if we said actually the sort of leads meeting might be more 6 weeks, try and get it in the end of August as people start coming back from annual leave before we then get into the September business mania, then fair enough. So it depends how strict you want to be in the context of a 3 month cycle about what we achieve in the first month.
No, that sounds about right. And maybe if with governance we could look at maybe when's our October meeting? Is it the end of October or the beginning? When did we? at the end of my thing, isn't it?
It's the 11th.
It's the 11th. So papers need to be done by mid-September, don't they?
Yes.
Because that's the other thing, is the 6-week paper running. But we could, how about if we did, yeah, if we got to the end of August for Leeds and then came back, if we met, if I kind of, we looked at something in kind of the second week in September, possibly, if people can make that, and then we could get back out in order for amendments to be made. Deborah, you've got your hand up. What do you think?
I'm thinking on my feet.
Think away.
So I'm really keen that we find a way of being able to address the issues that have been raised in terms of the communication of the actions. But what I don't want to do is all of the leads and teams to spend all of their time working another way of reporting something rather than actually doing the work that we need to do. So I'm just wondering, we've got our integrated delivery group meeting on Thursday. What I'd like to suggest is that we have a conversation there and maybe choose one of the areas and have a discussion in that group. And have a go at presenting something in a different way to send out, but just with one of the criteria, and then it would give people time to be able to feedback whether they think that's appropriate. And also it would allow us to focus our attention on delivery and not just on getting the reports right.
Yeah, that sounds perfectly sensible. And then you can report back in a couple of weeks, do you think, or after, or maybe give me a.
I'll do it as quickly as possible.
Well, or I was
And
going
it might be in a week. It depends on the level
just
of
an
conversation.
update on the kind of the way ahead. I'm thinking, rather than the piece of work. I didn't think you'd just have the piece of work, but just an update on the way ahead. Because then what I'd like to do is I'd like to have had it. I'm going to say sense checked, but you know what I mean, because we're a bit tunnely now because we've all been around here too much, around this delivery plan too much. But it would be good to get a wider sense check before we come back together in October. Otherwise, it just seems to me we're just pushing it down the line a bit just because time passes. So, and do you think then you could, the bit about linking up the outcome summary from public health into those the delivery plan, do you think that's something that within this kind of IDG bit, or is that a separate thing, do you think? No, Sarah, please, no, please do, come on.
I think that's almost your other half of your rag rating. So your two halves of your rag rating is your rag rating on your delivery, and then for each delivery action you'll have a number of outcomes that are in that other outcome document, and that's your that's your rag rating against your outcome. So I think you can bring those two together into one, and I agree with Deb, you could trial it with one, and you're effectively rag rating the progress of the programme and the project, but also rag rating the outcome based on the outcome paper that's in here. I mean, I think we might need to look at some of those outcomes again, but I think you could combine them together.
That's helpful. Sarah's the planning expert, not me. So if you allow us to have a conversation at the IDG, and we'll take some sort of a straw poll on that, and then we will come back to you with our proposed way forward, but with acknowledging that we need to have some engagement in that in time for when we produce the new reports for the next health and wellbeing board. It hopefully won't be another dry run. It will be, this is what we're going forward.
Yeah, that sounds great. My only slight hesitation is, and Dawn will be able to clarify for me, obviously, is there anyone from the Children's Partnership that's in the IDG?
There is, yeah.
Oh,
not this week, so I've got.
I thought, yeah, this is Clash City. So could I ask from a board perspective that Dawn and Deb and Dawn, after IDG, could you two possibly have a conversation just to confirm that whatever we've thought of would work well with children's, because I think that's the thing.
So Mel Thwaites, who's on the call, we've just had a quick instant message conversation. And I'm hoping Mel's going to be at IDG maybe on Thursday. And we'll feed in her and Bernadette's views around and represent in terms of the template, etc.
Excellent. So
If not, if not, we can catch up afterwards.
excellent. So yeah, so we'll oh, Mel's got her hand up. Can we I know she can't, we're not allowed, are we?
We're not allowed, I'm afraid.
I'm really sorry, Mel, we're not allowed, which does seem daft, but we would if you could email Dawn the answer, that would be fantastic. And Dawn will read it out for you. Thank you. The wonders of legislation. It is crackers. I apologise, Mel, but that would be really useful. I think it's really key that the two groups are working together and that they both can report the same way. And I know that obviously children's has their own specifics, so that's the only reason I'm asking that. I think if we can, if again is starting something from the start that works for all of us without reinventing the wheel would be great. So as a board, are we happy with that, the way we're going forward on that? I'm getting nods all round. Excellent. Now we're now going to move on to the communication strategy. I'm conscious though it's 3:20 and to be frank, I need a small break. So I recommend we just have 5 minutes to stretch. For those listening in, it's a bit hot and kind of grotty here. So if we have a quick stretch for 5 minutes, refresh our water and things, that would be fantastic. And we'll just come back in 5 minutes at 25 past. Thank you. Ladies and gentlemen, we will come back. And we are going back to the communications and engagement strategy, appendix D of so back over to Sandra, sorry.
Thank you. So again, I think we have here what is possibly a bit of a technical document, not a terribly friendly document, ironically, given the theme, but bear with me while I tell you, while I take you along a brief story, again, picking up on the theme of the day of sequence. So I think we realized very quickly that the joint health and wellbeing strategy actually had two Achilles heels, and that's not a good way to go forward. And that on the basis of what the public was telling us about what their needs are. And there were two clear sets of messages. One was about communications. People said they found it hard to find out what was out there that was available to them. They also wanted more education, more. When I say education, I say that in the very positive sense, not a patronizing sense. They wanted to know, how can I look after myself as my needs change and as new things arise? I end up with long-term conditions and whatever else. I want to play my part to have the best life I can. And we also heard from people that they didn't want an over-reliance on digital channels, because that excludes quite a lot of people out in our communities, and particularly, although very many of our older people are digital, not all are, and actually some of our younger people are not, particularly where the household is smartphone based and the children are not kind of included in that dynamic. So some really clear messages about communications, and then also a very clear message came back very strongly and from the consultation, which was that people were expressing a willingness to share their experiences and their views of care in order to shape service improvements. Now, those two aspects are absolutely critical success factors for our strategy. So it became clear very early on that we did need a comms plan, a comms and engagement plan alongside the strategy itself. Let me add to that there's a movement nationally which is pushing towards much more, and quite rightly so, much more meaningful engagement with the users of services and with the workforce around how we shape those services to really work for real people. So what I've tried to do in this strategy is to basically work from that. And when I say the next thing to say is that out of the need for the strategy came a working group which I should have actually been more explicit about in here, because actually it has been a very collaborative process. So Healthwatch Rutland are involved in that working group, and we've been treading a careful line and sort of working out how we work together to not also impede the vital independence of Healthwatch Rutland, while we have the benefit of their tremendous expertise in actually working in a lot of very creative ways with the public. Healthwatch Rutland, Citizens Advice, who also have a very particular view on, you know, and a particular relationship with the public, the Integrated Care Board themselves, the PCN, the local authority, particularly Adult Social Care, who are very engaged in the business of co-production, and that will only increase over time. So a number of, I don't think I've got everyone there, but a number of important partners also representing the ICB at LLR level, comms experts, but also people who just happen to, you know, who have quite a lot of involvement in working with the public. So what we've been trying to do first is, and you'll notice there is a lot of terminology in this document. There is very little, what I found was there is very little agreement about what we mean by co-design, what we mean by co-production. And it's really important that we reach a point where we are all clear around the table what we're talking about. And if we want to pull it back a bit or push it on a bit, we need to be on the same page. And I think initially we had a bit of head knocking going on, and it came down to definitions. We were actually talking about the same position, but we were doing it using different words. And so we've had a process of forming and storming to go through in a positive sense around what do we mean, particularly around those levels of engagement. How ambitious can we be? How ambitious should we be? Really important discussion. So quite a lot of that is included in the plan to bring you to that point in a journey. And I'm not proposing that we hang on to a lot of this as we go forward and turn this into something more practical. But an important aspect of this is that, yes, we've reached 3 priorities. The first is around communication and education. And it's not defined too deeply, because actually what it's trying to do is complement what's going on in the strategy. So basically, what does the strategy need by way of comms to be successful in its actions? We will support that. So that's the first thing. The second thing is this group here is pretty much unknown to the larger public. And you're doing important work, but you're also a door in terms of people having a point of view, and actually also the warm fuzzy feeling that there's a set of skilled people on their side, kind of negotiating a new way of working in health and wellbeing. So the second thing is how do we make sure that the Health and Wellbeing Board can be as successful as they have the potential to be by using more communication? And then the third is around more engagement. And what I mean by that is a two-way conversation about shaping services, which might be at a variety of levels. I mean, co-production at its furthest level says you involve the public and the workforce, not just in shaping what the service is going to be, but also in taking the decisions and in delivering. Now, that's quite a commitment for people coming in and wanting to have their say. So it's also about working out what, depending on what the domain is, what's the realistic level we should be aiming for, where everyone around the table is confident that they can play their part and they want to play their part and they're able to play their part in shaping things as we move forward. Certainly absolutely critical that we find more of those opportunities to work together, public, workforce, change operators, if you like, around how we shape our services. And that might be at different stages. It might be in terms of a service which already exists, but maybe has a lot of no-show. What's the reason why those people aren't attending? If we really understand that, we can do something about it. And very often it's not because they don't care, they don't want the appointment. It's all sorts of things around the sides of that. But we also might want to sit down and work with people around shaping services more fundamentally and more profoundly. So those 3 areas of work, the plan first is testing your appetite for those 3 pieces of work. And at the point when we're clear between ourselves about what that appetite is, then that's a tremendous moment to actually go out to the public. And what I'm proposing is 2 things off the back of this plan. The first is that we have a period of engagement now. And what I mean by engagement, I don't mean consultation. Do you like what we said? I mean, how are we going to take this forward together? So we have more conversations about what it means to enrich our engagement and to enrich our comms. And we weave that back into what's going on in this plan. And we really reflect that. And we involve groups, including the policy consortium, including whoever wants to have a say within that confined period. So that's the first thing. We form a position and then we have more of that conversation. And then the second thing is to also think about resources. And it's absolutely right. I think Janet alluded to this. We need to make sure that we are matching our ambition with resource. And we know that that is limited. There's a lot that we've worked out that we can do simply by working together more tightly. But actually, with a little bit of extra resource in the picture, in fact, I think it was John who picked this up, with a little extra resource in the picture, one of the things that we potentially need to do, or I would argue we need to do, is to sort of build a culture of that two-way engagement, which is also a bit of an adventure, a bit of a challenge for our workforce to hand over a little bit of power to the user. In terms of how things are shaped, so that we actually start to use toolkits, practical toolkits, to build a bit of a culture around engagement, where that becomes a much more routine aspect of how we shape services and how we solve problems. And children's services in particular are a really great example, because you already do a tremendous amount of that. I mean, you can't shape a youth policy without sitting down and talking to young people about what they want. And you're not doing that technocratically, you're doing it in a way where they don't need to hear about the machine. You know, they need to just, be in the room and shaping something. So we're at quite an exciting point in this. And absolutely hear all the points about, yes, this is a bit technocratic, and it is. But there's a spirit and a journey behind that I would invite you to consider how far we want to take.
Thank you very much indeed, Sandra. Do I have any questions from colleagues? Councillor Wilby.
Only because I've been so quiet for all this meeting, but I thought that was a really great, impassioned plea from you that was done with so much enthusiasm. Anything that caused me to look up was when you mentioned that the committees were suddenly thinking about putting the user into the mix. And I would have thought the user has got to be right at the forefront of your delivery type of thing, because you want to know what is good for them and how they're finding what we're doing for them. But I thought it was a great plea.
Thank you. Oh, sorry, John.
I could just echo David's point. Well said, Sandra. Agree with absolutely everything that you just said there. And it strikes me actually that we're very good. Well, I think we've been very good, and I like to think we've been very good at changing the culture, was the word that you used, of empowerment and a co-production with our staff to start to integrate services. And it is a challenge actually, and a very interesting opportunity to actually start that with stakeholders, other professionals and the public. And your service as an example is a real good thing that we can learn from there. So I would wholeheartedly support what Sandra just said.
Thanks very much, John. Anyone else? Comments? Janet?
Yeah, I support Sandra's passion for getting the public involved in what's going on. I'm sort of thinking on my feet a little bit, but one of the thoughts that went through my head was, this is really great. What to me was a prime example of absolute brilliant communication during the lockdowns was the weekly newsletter that we used to get from, well, we still do get from Rutland County Council. And that really kept the public on side, really knowing what was happening. I know not everybody is digitally enabled, and that was a weakness in it, but is that is that something that can be progressed further to involve people that don't receive it, or even let people know about it? So that's one of my thoughts. Another thought was, very often I think to the public it seems there's an us and them, and it's the council and the councillors, and they, forgive my language, but they feel that they can go on to Facebook and whatnot and sort of slag people off, the services, the councillors, everything. And whatever engagement is done has got to sort of get rid of that aspect of it, because it's not conducive, it's not constructive to good engagement. So on the sort of the negative side, I think that is something that everybody needs to be aware of, and to actually sort of.
John.
Yeah, again, really good point. We have to get across that this is a partnership. It isn't just the council, not by a long way, you know, and that must be the driver of that message.
Yeah.
Anyone else? No, I must admit, as chair and as someone who likes participation, I do like this comms strategy, and it was one thing that I kind of championed from the start. I think it is really important that we work in partnership, but we also work in partnership with the residents of Rutland, because we can't make them healthy without them, and so that's key. I understand it is a different way of working for some of our partners. They're not so, we all have different methods of communication, and I think that's key, that as a board we come together. So we know, for instance, RCC have a corporate communication strategy. We know other areas. We know the ICS is developing a strategy for itself. I suppose what I would take is this: if we do adopt this strategy for our place and for our health and wellbeing board, it is for messages from our health and wellbeing board. As a note, one of the things I found, as members of the board are aware, when during the pandemic, I was putting out social media and comms regarding the vaccinations, which people were needing, and actually it highlighted to me how problematic comms in a particular area can be, because I was going to 3 or 4 different places to find the information in order to put it out. So actually, I think that's where a comm strategy is really needed, so that we can coordinate our messages, which is key around health, public health. Some of the public health messages, it is key that we do coordinate, and also that we have, I would suggest, a one-stop shop for where people can just get one message for Rutland, whether it be whatever partner is sat around the table, that one message comes from one area, which makes it easier for someone to know, oh, I want to know something about this, let me go here. And that would just make it much simpler. So I don't know whether that's something partners will agree with. Janet?
Yeah, when we were doing the What Matters to You project last year, that one-stop shop was actually suggested. I think the words were something like, we need just one person we can go to who can point us in the right direction and tell us what's there. And I think that can be done digitally, but I almost wonder whether, I don't know what the resources are, but I wonder whether there is something where it can be face-to-face, probably citizens advisor or somewhere, I don't know, but that came out loud and clear.
Thank you. David looked like he was going to talk. I could see his thinking had gone on.
Yeah, I agree with the one-stop shop totally. If I tell a war story, on a station, a flying station, if you have a crash, all the communications go down, and it's the station commander who tells the message off the base, so that there is no twists and nothing there. They get it from the horse's mouth exactly what's going on. And I think, Mike, you were probably in the position as the public health for, you know, pushing out the information during the COVID type thing. And I think we, you know, we respected that. And I think there's no doubt it's much better to get a clear message that comes from one source so that you can get it and then ricochet it out to other people, but with that, you know, fidelity on it.
Thank you. Right, so I think we'll bring that to a close. So I've got under item 10, we've got to note the further development of the joint health and wellbeing strategy delivery plan coinciding with the July transition to the integrated care system and the summary of progress to date. We've done that. We've endorsed the direction of travel of the associated communications and engagement plan and approved the public engagement to enhance and refine that plan. And that as a plan is not cost neutral, the development of an options appraisal addressing what could be achieved under the plan with different levels of sourcing. And I would suggest that along with that business plan, we look at there being a standalone, or not a standalone, but the one-stop shop approach, maybe through, so that comms could be directed through, and I'm going to say Health and Wellbeing Board, but through a one channel, so to speak, that might work better for the whole community, bringing in, and within that, I also think about that cross-border communications as well, which I think are key, so that everywhere is coming from the one thing, and partners will then be clear how they get the communications in, and I think that might well work. So we'll over to Sandra to do that. So we need to take a vote. So that's what I'm proposing. We have the action from previously as well that you've noted for me, don't we? Yes. Oh, thank goodness. And so if I could, I'll propose that. If I could ask for a seconder, and then we'll take a vote. So John's going to second for me. And then if everyone was in favour of those actions, if you could show your hands. Thank you. That's unanimous. Thank you. Now, I'm conscious of time as we're moving on, because as usual, my timings have gone out the window. I did even time this. So we've got the next one again is over to Sandra. It is the Better Care Fund. Now, I know we are noting this, and we do obviously want to give it its due, but if I could ask that we're quite succinct, and as a board we are noting this, but if we do have any questions, so we'll move on to agenda item 11, please.
Thank you. So keeping it very brief, and I'm sorry I just stepped out.
That's fine.
Yes, apologies for that. Better Care Fund. So we've just handed in our report on last year's programme. I think we had a pretty successful programme in the circumstances. Went to plan across most of the measures. The more interesting thing to talk about is the next round, which we are halfway through almost. So this is the world of better care. So we're expecting the policy guidance and the planning guidance for this year's Better Care Fund round any day now, actually. And then there will be a period of probably 6 to 8 weeks before there's a deadline to submit a programme. So this is quite unlikely to sit well with the Health and Wellbeing Board rhythm. So what that means is most likely a delegated decision on that programme. Really at this stage, we're in a process of minor amendments to the current plan. I think it's reasonable to say, but what is more interesting is that for 23 to 25, they're proposing a 2-year programme, and we have a better opportunity then to actually, and in theory, the policy guidance for that programme should come through within this financial year. That would be a very welcome first, I have to say. So that we have an opportunity there to adjust and tune our programme towards really, I mean, they are already aligned, but to really more explicitly be supporting our joint health and wellbeing strategy. so that maybe potentially we restructure. At the moment it's a 3 priority programme, and potentially we would restructure it and rebalance it around so that things feel much more like it's the same story going on, because actually it really is the same story going on. So that's the proposal. Funding for this year is pretty much on a par with last year. Small inflationary increase, which in previous years would have beaten inflation, but this year doesn't, obviously. Well, I hope that summary puts you in the picture for the current process, and certainly look forward to the point where we can be having a richer engagement and conversation about these programmes, which hasn't been possible of late with the timings.
Thanks very much, Sandra. Any questions, Janet?
Yeah, it's about inflation, because if you've had a smaller than inflation allocation, and inflation is rising and forecast to rise even further, how are you going to support your staff to deliver the care, to get to the patients, to deliver the care on, you know, how you're going to have the funds to support them to cope with inflation in their charges for getting to care, or are they going to go elsewhere?
I think that's a question we all face, isn't it, as we move along at the moment. I suppose if I wanted to reassure at all, wages are not keeping pace. And so from the point of view of straight cash in the programme, that's not where the stretch is. The stretch is in terms of the reality of people's lives, isn't it? And that's something that we're facing across the board.
But what we're already beginning to see is industrial action.
Yes.
Because wages aren't keeping pace with the rising cost of living. And I don't want to be the bearer of bad news, but I think it's something that needs to be considered, because industrial action amongst carers, because they all walk in, because it's not worth them actually getting the car to drive to wherever. It's going to be a really serious problem.
Thanks, Jenna. I think Mike might come in, but I'll offer some reassurance that obviously, certainly for RCC employers, there is it's a national pay scale, and so certainly I think they've only just finished last year. So whilst you're right, inflation is much higher, that the chances of the pay being finalised this financial year, I think, is down to about 0 at this point.
Yeah, thanks. I suppose it's just to be more specific, because it is going to be a big issue. I guess in terms of the Better Care Fund expenditure, so 21-22 not affected, that's been gone. The future plans 23-25, actually sort of answering my own question, we're not there yet. So actually because I was going to ask, what are we not going to do? I suppose the point is there's things on the horizon, but there's nothing in this paper which would determine yet that we're having to cut things, because we're not at that stage. Yeah.
Thank you. Were there any other comments? No? Okay. We will note Janet's concerns, and certainly we will take those comments into the following year's comments, which I'm sure the government will address, but we shall see what they come back with what they say. What I would like to do, this was down to actually noting, but taking on board Sandra's comments, I think it might be worth us. We're going to note the Rutland 2021-22 Better Care Fund end of year return, and the submission to the BCF national team on the 27th of May that was signed off by myself. But rather than noting, we'll note the update on the 22-23 programme period, but if it's acceptable with the board, we'd also vote to defer the decision to the chair and the director of adult social care if required, should we fall out of period. What just to confirm what I'm trying to do, I'm desperately trying for us to have the October meeting in online. So I'm trying, if we have to take decisions, we have to come in person. So if we can defer this, it means that we can save our pennies on the petrol and so on, and partners don't have to travel so far. So I don't know whether the board's happy for that deferment, but it would just be, it's just so that we wouldn't be coming together to take a vote on it. We can defer that. Obviously, we will come to the board, but it's just so that we can defer the decision. So we can make the decision in principle online, but defer it. It's to get good governance. Are people okay if I propose that? And can I ask for a seconder? Thank you, Dawn, and all those in favour. Thank you very much indeed. Thank you. So now we're on item 12, which is the update from the subgroups. We're looking to Councillor Wilby to update on the Children and Young People's Partnership, please. And sorry, Councillor Wilby, can I ask you to move your microphone towards you just slightly so that we can hear slightly better? Thank you.
Okay, can you hear me? Let me say that the Children's Young People's Partnership, I think, has been very vibrant. We've had some really good meetings, and in many ways, the virtual way of doing our meetings has helped because it saved some people traveling a long way, and we've had inputs from everybody. I'm going to do a hospital pass and send it straight across to Dawn, who I know has just put together the next meeting for next week, which I'm not going to be there. And I know she's got some exciting things to tell you.
No pressure. So in terms of the Children and People's Partnership, a couple of things. The first thing I want to say is one of the really big achievements for the partnership has been the recommissioning of the 0 to 19 Healthy Child Programme. It was really big piece of work, and actually I want to pay a lot of credit to public health colleagues for their support and leading on this. So that is, we have successfully recommissioned, and we are interviewing at the end of this month for 2 of the key posts for the 11+ service. So that's really positive. And the other big achievement has been around the Reducing Parental Conflict programme that we've secured continued funding for as well. And that's been really important for Rutland, particularly not just for the Rutland community, but we've had really good engagement with our service families and local bases as well regarding that. So that's great. 2 big pieces of work, and this one's long term, one is shorter term, is the Family Hub development. We have got a programme manager who is responsible for the kind of delivery of the Family Hub programme. Unfortunately, we have funding for her for that post, 1 year funding, but we do not get any central government funding for the actual delivery of the Family Hub developments themselves. And that is very unlikely to change because of where Rutland scores in terms of deprivation indices. So we're being creative, as we often are in Rutland, and innovative and all of those things. So we've already near completion of phase 1 of the Family Hub development, and that's been around looking at needs assessment, really engaging not just statutory partners but very much voluntary and community partners, as well as parents and young people. So that kind of preparatory work, if you like, around a needs assessment and kind of looking at what the art of the possible is as well, is nearing completion. We're moving into kind of the kind of delivery phase and an actual delivery plan. So that's that's on the agenda for our Children and People's Partnership next week. So I'll have a better update following that. And then the other really big piece of work is around increasing the mainstream secondary provision for children with additional needs. So this is due to be delivered September 2022 at Uppingham Community College. And that will be a mainstream plus provision. As I said, it's for children with additional needs who may or may not have a EHCP, and the idea is about it's very much aligned to our inclusion strategy, and very much about keeping our young people with additional needs local, both in terms of their community, their support networks, their families, and also maintaining them within a mainstream provision that meets their needs. And that's the important thing. This isn't about their needs not being met. This is absolutely about how mainstream provision identifies and changes the way they deliver the curriculum to children with additional needs. It's not about children having to fit in with a curriculum that schools just offer everybody, and that's a real switch. That will take some time. That takes time over in terms of for every school to really be able to kind of switch into that. But actually, we're starting from a really positive base. So yeah, so that's us.
Thank you very much, Dawn. That's fantastic. And over to Deborah for the update from the Integrated Delivery Group, please.
It's a hard act to follow, Dawn. So the Integrated Delivery Group has taken on a bit of a change in focus. I've taken over as co-chair from Faye Bayliss in March, and John and I think do a good job co-chairing together. I could just pass the baton to you, couldn't I? But I wouldn't do that.
Thank you.
So we've tried to change the focus of the way the Integrated Delivery Group works away from just managing the business of Better Care Fund, which is really important business, but in to more around delivering the and developing the plan of the health and wellbeing board strategy. From the adults' perspective, obviously, there's the separate children's group. Some of the work that I think that we've done, which isn't yet as visible, is the better integration of partners around the way in which we work, and I think we've seen quite a step change in that in the last few months. Getting all of our partners on board, and we've also set up the strategic health development group around the health element, particularly of the health and wellbeing plan. What we're trying to do is to broaden the scope of the IDG to be able to encompass all of those elements. John, do you want to add anything?
No.
That was a useful contribution from John there. Deborah was hoping for a big long list like Dawn did then.
No, there has been some good progress. We've been working closely together. Rutland is a place that's really coming to the fore, places primacy. I think we're interested in developing further the foundations that we've already built. So we've got the integrated hospital team, for example. We've got the integrated team with the PCN, the RISE team, the MyCare, the embellished public health team. And I think around RMH indeed, looking at some practical ways of building on those foundations and we've been using this term, haven't we, a care and health system for the Rutland place, which is something that we are very interested in taking forward.
Thank you. moving forward, because obviously we have the update from the subgroups, we're going to have that as standing items, as well as the joint health and wellbeing, the kind of delivery plan. What I'm thinking is if we've got our house in order with our those summary sheets and the summary way forward, do we think it would be moving forward, what I'm thinking for the agenda and things, do we think it would be a good place within the updates from the subgroups for you to report back on those summary sheets? Do you think that might be useful as a useful place for that feedback, and then we could maybe as a board steer some of the challenges back or not? No, that's fine. No, it's
Chair, shall I?
yeah.
Shall I come?
So it's perfectly right. My brain works in a very weird way sometimes. So do you want to come in, Deb? Did you know what I was trying to?
Yeah, I think I'm with you. but then I might prove it wrong. So instead of having a separate response to the delivery plan item on the agenda, that we respond on, once we've worked out what the report's going to look like, that we respond on our update of the health and wellbeing strategy via the updates from the subgroups. Is that what you meant?
That is what I mean. So these, I'll hold them up. You know, these bits that we looked at, Appendix A, where we were going to tweak them, because then what I thought was if we separate them from because we're always going to have Appendix B and C, the main green plan and the public health bits, we're going to have to bring them in. So it's also always going to look really bulky if you were looking at it from an outsider. Obviously so what I'm thinking is if we could bring in the Appendix A into the subgroup feedback bits, it would separate them and actually might make for easier consumption. Sorry.
Yeah, I mean, I'm always for simple and easy to read. So yeah, I will always support that. The one thing I would just say is that in terms of the children and young people's plan, there is more in the children and young people's plan than just the health and well-being strategy priorities, which are really important that we don't lose sight of. So whilst I support some sort of amalgamation, what I wouldn't want to do is for the Health and Wellbeing Board to think that that's their only oversight in relation to the children and young people's plan, because it isn't.
Hold that thought, and then I'll bring Deborah in, and then I'll come back to that thought.
So I was going to add something, but then I think I'll try and respond to that as well. So the way I would see the IDG reported is to have the update from the health and wellbeing plan that's part of that reports into the IDG. But I'm really keen to have the stories and the separate updates that we discussed earlier, so things like primary care, etc. So I would see the update almost in two parts, and maybe the children could do the same. So there's a response on what's actually in the strategy, the health and wellbeing strategy, but then there's your broader report, because as you said, you've got a gender and a strategy in its own right. Maybe as a suggestion.
Yeah, I'm happy with that. Are you? Does the rest of the board see a benefit that? I just think it kind of because the core reporting back from the two subgroups speaks to how the strategy is going and things. I think it would just make it easier for the public, because it would separate them out from the huge plan, and would mean, but we can talk about it. Do you not know what I'm talking about, Janet?
No, I was hoping the last time, sorry.
Okay, so in the previous bit where we spoke about the strategy, we spoke about Appendix A, which were the summary reports. What I'm suggesting is, rather than reporting the summary reports, the strategy reports, the summary report from the business from public health, and then the full plan, rather than doing all of those three bits together as a standing item, we separate off what we have now as Appendix A in item 10 and report that back from the IDG and the children's group separately, and then they also talk of the other work going on within their arena. What it will mean for the papers is that it's just a bit easier to read, because it's not, I'm going to say, death by PowerPoint or death by Excel. What you're not being confronted by is hundreds of pages of things, and may make it more easily digestible. But that's based on the previous discussion we had about how we were going to slightly amend. So it might be once they're amended that's not going to work. But what I'm trying to do is think on the hoof and actually make it more digestible. So I suggest we run with it for maybe the next time, and then if it's not working, we'll just think of something else. I'm just trying to think of the best way for the information to be digested. Sorry, Sandra, you want to come in?
I'm going to ask a cheeky thing. Brace yourselves. Do you definitely always want to see that delivery plan? Because the slides above it are actually, you know, do you want that level of detail all the time? Will you genuinely dip into it? Or those summary slides are really, I mean, they are trying to convey what's going on in the priorities for the strategy. So it's about finding a balance, isn't it? Because if you present those tables on their own, then I completely agree. You've got a box of Lego bricks. That's all.
So are we suggesting then? Oh, okay. So, all right. Sorry, Deborah.
So this is where I'm showing I didn't fully understand you, because that's what Sandra's suggested is what I thought we were going to do. So we would have the summary sheets as part of the IDG, but not the detailed plan every time. Because actually, I think, to be honest, for people reading board papers, whether it's the public or members of the committee, to have a massive, and I actually printed them out this time because I was having a problem with my computer. Don't normally do that. It's a massive pile of paper. So if we can, as part of the discussion we had earlier, we can make the storytelling, the communication more succinct. If then members of the public or the board want any specific detail around a programme, we can supplement that by sending that out later.
Yeah, that's a plan. I was going to say, hold that thought, because if we had, we'll come on to any, well, I could just say it now. What I did notice, the bit that I found that was missing from this, and I was bringing it up in any other business, was within scrutiny, we have performance data that comes round. Now, I know it's at ICB board level, it's published. For Rutland Scrutiny, they do on a quarterly basis, and it's released just before our meetings, actually. They send performance, and it is East Leicestershire and Rutland because of the way the ICS has to collate the figures. But it does include our cross-border data as well. So it's really interesting data set. Now, it doesn't currently come to the board, and I was going to suggest in any other business, I do believe that the board should have sight of that within their papers, so to speak, so that we can have a watch over it, so to speak, as a board, and we can see where there are any things coming on. Now, it wouldn't be additional work to bring that forward. I'm looking at Jane here, because it would just be, it's already published for scrutiny, which run a week before these papers. So it's already produced for another meeting a week before. We would just need to append it as noting and just have it as a noteworthy thing. We won't discuss it unless somebody has an issue to it, and which case they could raise. So are we suggesting that we have a data set? I'm going to call it a data set, but would it be helpful to the board to have some background papers attached, which we could include the delivery plan per se as one of those, so that we have members, because you're right, Deb, I mean, look at my War and Peace here. We could have it so that for the actual meeting, we would only print out some, but for those of us that that prefer the more in-depth analysis and things, those papers would be available as appendix, but you wouldn't need to print them and bring them along. What do people think to that? Deborah, you've got your hand up. Mike's got his hand up. Here we go. I've started something now.
There's a balance here, isn't there? And I think, so I've got 2 points really. I think it's difficult to produce. What you don't want to do is to have an item discussed in 2 different forums by the same area. So there might be a danger in allowing people to raise something from those papers if it's already been discussed at scrutiny the week before, because what you don't want in any public documentation is a different answer being given, a different comment. So there's always just a little bit of a risk there. It doesn't mean it's impossible. And I suppose the other element, if it's for noting and information only, if somebody raises an issue with it and not everybody has gone through it and gone through that data, again, sometimes it can make the conversation quite truncated. So my preference would be to say that those items are available if people want to look, but that we don't formally append them to the board papers. But that's just my view. So
Mike.
And from me, I'll tell you what I want, what I really, really want. I've no desire to look every meeting at 104-point delivery plan. Whether you append that delivery plan for information or not, I don't mind. I'm probably not going to read it myself. What I do want to happen is for the subgroups to own the strategy. They own the detail. They then do the update to this where they highlight, as per the templates, the big issues that they think we need to spend some time debating and coming up with solutions. And I just had a quick check. There's nothing in those 7 priorities which isn't covered by the 2 subgroups, because I was rapidly thinking if we covered everything in the strategy by the subgroups, accepting the subgroups have got a bigger agenda than the strategy, but actually it'd be quite nice to hear about the other stuff as well. That would do it for me. Otherwise we'll be duplicating and going over it. I mean, you can always put the detail on a file store if we wanted, but probably not formally appending, as Deborah was saying.
Okay, so
I would agree with Mike, but I'd just add one more thing in, then you could do a year-end report of progress against the delivery plan and then an update for the following year, because you might want to add some more actions in. So I think you you wouldn't normally see a delivery plan at every meeting. So we've effectively set the delivery plan now. The updates will give Health and Wellbeing Board a sense of progress. If there's anything to escalate, then the responsible officers and groups need to escalate that up. And then you do an end of year report that basically says, this is what we've achieved against the delivery plan. Here's the delivery plan from last year. This is what we've achieved. And this is the delivery plan for next year.
yeah, are we happy with that as the way forward then? Excellent. Right, that's it. I'm lost now. Where was I? See, that's what happens when I sidetrack. We go. Oh, item 13. So, but did I do a vote? Oh no, we didn't have to do a vote. Right, we've got my time management is out the window. We've got 30 minutes, so I'm going to be really strict now. She says we've got 10 minutes for item 13, which is the joint strategic needs assessment. We've got the report. It's at item 13 and it's being presented by Hannah, who I think is online.
Actually, Chair, I'm going to introduce on Hannah's behalf, but Hannah is on the call to answer any detailed questions.
Oh, okay. Thanks, Andy. So,
Okay.
Sorry. So over to Andy then, and that's great. Thank you.
Thank you, Chair. Yes, the report before you provides an update on the scoping work that we've been carrying out to commence the process for the refresh of the JSNA for Rutland. And as I'm sure the board is well aware, the JSNA plays a key role as the evidence base, assessing the current and future health and wellbeing needs of the population, and really underpins local planning, commissioning of health and care services. The last JSNA, full JSNA was completed in 2018. In the last couple of years, when we would have been looking at the refresh process, our analytical resources have been heavily deployed towards supporting the COVID response. However, as some of the COVID intelligence work is becoming a little bit more mainstreamed, we are now looking at a suitable process to refresh the JSNA, really in the best possible way to help the board in its work. We have been looking at best practice elsewhere in terms of the structure of JSNAs and the approach, and the report sets out our initial thoughts on the approach for Rutland. In recent years, many JSNAs in a number of areas have been developed more as active ongoing evidence sources presented visually online through dashboards, but with summaries of key points, allowing for more frequent updating and more accessible information, and including a sort of assessment of health and social and economic trends as they occur. So we do want to try and incorporate some of the technology and ability to get intelligence to you more quickly. But also we do want to bring forward more in-depth reports and summaries of key topics for the board as they're required. So we are suggesting in the report the process is undertaken on a rolling basis from 2022 to 2026. And paragraph 3 in the report sets out some of the suggested structure, and we very much welcome the board's input on that approach and those priorities and comments on that. One of the key factors in terms of the timing has been waiting for the census data, which you referred to earlier in the meeting. So we have had the high level population and household data come out now with more detailed data, particularly around sort of health and demographics coming out later in the autumn. So that's really important that we get hold of that and we can feed that into the chapters as that becomes released, so that you've got an evidence base that's really up to date and underpins your work. Work's also progressing on a number of intelligence topics. We've got the P&A coming up on the agenda, also health inequalities for the next meeting, oral health and end-of-life care. So they're planned to come to you anyway, moving forwards. So that's all I wanted to say into the introduction. So we do want to note and comment on the suggested approach, and any priority areas you'd like to see come forward earlier than others, and to just note the kind of that census timetable, and that some of that will be very useful for as that gets released for later chapters. Thank you, Chair.
Thanks very much, Andy. Sarah.
Thank you. There's a couple of things from me. So I would be interested in the population growth one relatively early, if I'm honest, because that's obviously a key issue, isn't it, for us in terms of how we plan health services going forward. I think we also should just test ourselves on the ethical access to services, that we're not duplicating other work that's going on there. Just think we just need to test ourselves on that. And then finally, I'd just like to suggest that we think about health inequalities within the Rutland context within this JSNA, if I'm honest. So we know, don't we, that relatively Rutland is not in the lower quartiles of deprivation, but there are inequalities that exist that are different. And I wonder whether we could explore that a little bit more as part of this work over the next few years. Thank you.
Thank you. I'll let Mike come in, but I've just had a message from Viv, who has got to leave in a few minutes. So I didn't know whether she had any comments just before she had to pop off, because she's only got a couple of minutes left. So if she had anything she wanted to say, and if not, we'll say goodbye to Viv and thank her.
Thanks, Chair, much appreciated. No, not much to add other than thank you for Andy and Hannah for pulling this paper together. I think for me, it's really about thinking around how we can utilise the JSNA in that wider population health management approach, which is why we've gone for proposing an approach that takes more of a reflective and updated version, rather than having one JSNA that's one document that's great at that moment in time but then becomes out of date very quickly. So it does mean a slightly different approach to the JSNA. So obviously there would be sort of a really useful background data set, but then there will be these deep dives on these particular areas of work. And just picking up on the health inequalities point there, Sarah, one of my team, Mitch, is currently doing the JSNA on health inequalities for Rutland, so that will be coming to the next board hopefully around that, and that will look at some access issues around services. So I know there's a lot of work that your team has been doing on that, and he's been linking with your team on that. So yeah, it's about just thinking about a slightly different approach to the JSNA, so it's more relevant and hopefully more effective and really builds that cornerstone of that population health management approach. But that's all from me, so thank you very much.
Thanks very much, Viv, and we'll let you go off to parents' evening, which is really important. Sorry, so I think we had Mike who was going to come in next, and then Dawn.
Yeah, nothing much to add, just to sort of echo Viv's comments and also Sarah's, because I think the big one, Andy, is going to be census data. So that is the first priority. I was just going to ask though, I know it's a rolling programme, everything that you said, what's the end date for finishing rolling? I think, did you say at the end, sometime in 2023?
I think we felt it should end in a complete manner before the new health and wellbeing strategy is done, which I think is to 2026. So it will be sort of a regular updates within that, but then more deep dives that cover the full strategy elements over that period. So really sort of a three-year period.
Very rolling. Does that mean, my only concern with that, I'll let you come in, Dawn, in a sec, but my concern with that is that we will need to update, we'll need to have a very strict programme then, and a show that we are, my concern is our JSNA is currently on our website out of date, and I don't need to reiterate to the board that this is one of our key priorities from a board. I think if we're then suggesting that we're not going to have an in-date JSNA for another 4 years, that's too long. I hate to say it. Mike, do you want to come in on that?
Yeah, I mean, Andy, I see what you think. I mean, I would suggest we wouldn't say we haven't got a JSNA, but we'd put on the website exactly that, you know, we've switched to a rolling programme over the next 4 years. The content as it comes through, starting with census, goes up there. Because it just feels like we've really moved away from actually ever publishing a finished document, because they are out of date the moment they're finished. And it is more about referring to some kind of data dashboard. So trying to find a balance of saying, no, we have got one, it's just not in the format that it used to be. Is that what you're thinking?
That's really helpful. Yes, we do need to refresh that website content. There is some more intelligence that's come to the board in that time that we can put on there. As I say, there will be a few key documents coming through shortly as well that need to be referenced. So we will update all of that content and then add to it on that rolling basis.
I think, yeah, the only other kind of thing I'd suggest is that we, and which chapter it fits into, probably the population growth, but my concern is obviously developing the local plan. It's essential that we have an up-to-date JSNA with that section. I cannot reiterate enough how essential that would be, that is part of it, in order that for colleagues around system level for services as well. It's the cornerstone. So I think whilst I agree that some could be rolling and certainly have that work program, I think we need to have a core ones that have to be kind of committed quite quickly. Sorry, Mike.
So again, just to come back on that one and Andy, bring you in, and within that, we're definitely saying the census data population growth is first out the blocks.
Yes, absolutely. One of my colleagues have already teed up to start looking at all of the census information. I think we can bring something as a kind of headline to the next meeting, but it won't have the kind of next level of detail that will come through the next release of the census. So it's just a bit of a trade-off between what you get when and then what level of detail you need in that. So certainly the high level stuff, we can do a quick picture of the growth trends, comparing this census with the last census, and just some headline demographic information, particularly around the growth of older people. But it won't have the next level of granularity, if you like, particularly around ethnicity, and some of the more detailed demographics that are really important. You get into some of that detail. So that'll probably come in a phase 2 document, if not in the autumn, then certainly very early next year.
So we've got Sarah and then Dawn, please.
So will that, Mike and Andy, include predictions not just based on sensor data, but based on predicted housing growth?
I think we will be looking at the housing growth figures as part of that. I mean, some of that's subject to review anyway by recent government announcements around the housing process. We have looked through the P&A process to try and capture some of the latest intelligence around housing growth with colleagues in the CCGs. So certainly we can look at that element and try and bring that forward. It's not an easy area with some of the changes that's happening nationally, but we can certainly try and unpick that for you and bring that through.
So that's also a discussion with the planning authority here, isn't it?
It is,
yeah.
It is, yeah.
Yeah, and that's one of the concerns one of my reservations is around the fact that we're the local, and obviously we've got options and issues and options. Is that what? Yeah, that's what it's called, isn't it? Out for consultation now. We need to develop these two kind of hand in hand, because otherwise we're going to come to the end of the process. My concern is the date of 26. That's the time when the time of an adoption of a local plan, and what we want is them both to be together at that point, not far apart. So that's kind of the key to that development, which is why I think as a board we need to just keep that in mind. Sorry, over to you, Dawn.
Thanks. I mean, I think the benefit, from my point of view, I think the benefit of the new approach, if you like, to JSNA is actually that we can be more agile in terms of when, as issues arise, we can kind of think, actually, we need to have a deep dive into that rather than, having a massive piece of work done that's out of date pretty much as soon as it's written. So I think that's the beauty of the new approach. From my point of view, there's a couple of areas that I'd like to kind of make sure we're kind of covered off in terms of a deep dive areas, and they cut across several of the priorities. So best start for life, that's obvious, but also in terms of mental health and COVID-19 recovery. One of the things from a children's perspective is around the impact of COVID on very young children who in their first year have been born and not had any socialization. Actually, they didn't access early years and still aren't in some cases. So and what I'm getting from my primary early years sector, but also my primary schools, is actually around that it's not a developmental delay in the medical sense, but it is about how COVID has impacted on their social abilities, let's say. And that also links, as they're getting older, into social and emotional mental health needs. And we're seeing in Rutland a far greater number of children being diagnosed with autism. And in terms of EHCPs, social, emotional, and mental health being the kind of reason for the EHCPs, then that won't be just a Rutland issue. Actually, I think that's replicated. So that would be an area of deep dive that I would be really keen for us to kind of look at early in the kind of round, if you like, because I think it cuts across not just a number of areas within the joint health and wellbeing strategy, but equally in terms of thinking about some of the other wider Rutland strategies and things like SEND, high needs block.
That sort of thing.
I could go on.
You could go on. I'll jump on your children's just because you've mentioned it first. The one thing I would like is as well, and I think we probably are incorporating it, that I need to look at the kind of those neonatal and stillbirth figures that are in the summary analysis on Appendix B of item 10, where our figures are quite bad and we're not sure why. I think that would also be an important part of the JSNA, so we can start discovering or start having a look into maybe why some of those, and then that will also come up with move on into the children's. Sorry, any other comments? No. So, and then the only other thing, and I think it's here, the oral health needs assessment, obviously in our lovely paper from our colleagues that went to health scrutiny last week, did infer our lack of JSNA in that area, meant that they couldn't plan services. So I know, I know. I might have said something very similar. There was an F from me, but it's just a sense, and obviously I'm very conscious that the ICS and ourselves are inheriting the dental debacle, I'm going to call it. So I do think that actually I don't know whether Andy agrees. I know it is on there is talk to see if Public Health College can bring that one forward, but actually it's let's just say the papers that went to scrutiny were interesting. I can give you a copy should you wish, but yes, they were quite happy to throw us under the they did mention us actually as the Health and Wellbeing Board as well, and tried to throw us under the bus, but it's not the bus I'm going under. Anyway, so if we've got no more, we needed to note and comment on the suggested approach, which we've done. We've suggested some priority areas. We've noted the latest census timescale update and that data releases will be useful. And we note the supporting analytical work which has been progressed on the PNA, health inequalities and end of life. What I think might be useful as a board, and I don't know, hopefully it wouldn't be too much work, Andy. I know in October it might be useful if we could have maybe a time frame so that we would have some sort of time frame of when things were coming in and how we would oversee that. I think that would be useful. And I'd also remind the board that we did pass in, I'm going to say February, and hopefully Jane might remind me, that we did pass that we would have an annual workshop day for the JSNA and also the strategy to link the two together, and we would have a workshop. We had courts, we had agreed as a board that we would do that. So if we could incorporate the annual day, which I had a feeling we thought would be September, October time, or am I making that up? The timing? I'm making it up. I'm not. We did say a time. I just can't remember what it is. I might have been making them. We will check the minutes from that meeting and see what we did decide. We did decide on a rough time area because I remember the discussion. So we'll come back if we can liaise with Andy outside regarding that. Are you happy with that, Andy?
Yes, actually, it'll be Hannah Blackledge who's doing most of the work on this. Hannah's on the call at the moment. I don't know whether Hannah wants to just pop on just to say hi. She's joined us a couple of months ago, and she's leading a lot of our work on JSNA development, particularly for Rutland. So I think Hannah's been taking notes of your priorities and giving it a real thought. So just to sort of say hi to Hannah, and that Hannah will be the person involved in the detail. She's absolutely excellent. Has got tremendous expertise in this area.
Thanks, Andy. Hi, Hannah. So are you happy with that as and we'll liaise outside of the meeting just to confirm what we'd already kind of voted on a couple of meetings ago, just on how we were going to progress forward on it?
Yes, that would be extremely helpful. The discussion was helpful, all is noted down. So it's very helpful to know which things to start with, and hopefully it will be a helpful piece going forward.
Thank you very much indeed. So, board, if we're happy with all of that, I will propose it. I'm looking for a seconder. Thanks, Deborah, and all of us in favour. Thank you. Janet, are you voting? That's all right. Thank you. Right, so Andy, you're up next, I'm afraid. We've only got 20 minutes left. We're going to have to be really quick. We've got the Rutland Pharmaceutical Needs Assessment. Over to you, Andy.
Yes, I'll try and be quick just to introduce the paper. The report provides the board with an update on the work we've undertaken to produce the draft PNA for Rutland for 2022 as a basis for statutory consultation that we launched last month. And we're very much seeking the board's comments on the draft document and all of the content that's in there. Just a reminder of the purpose of the PNA is to identify the pharmaceutical services currently available, assess the need for them now and in the future, and inform planning, commissioning and decisions, particularly by NHS England, to allow new pharmacists to set up. It is a statutory document covered by a lot of detailed guidance and sort of set processes that would need to follow. The overall process has been overseen by a partner reference group, including NHS England, the local pharmaceutical committee, local medical committees, CCGs, and really helpful input too from Healthwatch to help shape the document. And the draft document is set out in Appendix A with more detail set out in the supporting appendices. So we have tried to streamline it somewhat this year so that it's more manageable to understand. In terms of just some of the key highlights, clearly in terms of the census information and also the population information, it does highlight the importance for Rutland of really good pharmaceutical needs provision, both for children and families, but also for the older age group population, which are overrepresented in Rutland, particularly in terms of issues such as hypertension and heart disease, cancer and asthma, etc., where there's a higher degree of prevalence than in other areas. It sets out in a lot of detail the current level of provision with 5 pharmacies and 3 dispensing GB locations, 100-hour pharmacy as part of that. And the overall picture for Rutland is 2.0 contractors per 10,000 population when you do include those dispensing GP locations, which is fairly close to the average of 2.2 per 10,000 nationally, so just under the national average in terms of sort of physical access. But we also understand the need to access important pharmacy provision in Stamford for those living on the east side of Rutland. The census information that came out was fairly similar to the forecast population through the ONS estimates in 2020. I think the report's got 40,800 in where the population was 41,000, so fairly close in terms of that. But also the importance of sufficient public transport and community transport provision to maintain access to those services is really highlighted through the work that we've done, particularly for the more deprived communities that don't have easier access to a car. The report looks in detail at the advanced services, the essential services and community-based services. And it's interesting to note the extent of advanced and community services now and the role that pharmacists play in a much broader range of provision than their traditional one around medicines access. So the report does set out quite a range of services from a number of the pharmacies now in Rutland, which is good to see the enhanced role that's being played. We have promoted 2 surveys as part of the document preparation, one with pharmacists and one with service users, and we have reflected some of the feedback around those surveys into the report. So generally from pharmacists, we are hearing that pharmacists have been under a little bit of pressure, some workforce pressures, particularly needing to use locum pharmacists and relief pharmacists, and some recruitment difficulties experienced. But also some respondents, or most respondents, feeling they are able to maintain the current level of service. And many of them also willing to provide more NHS commissioned services with training facilities moving forwards. And most pharmacists felt there was a reasonable number and extent of pharmacies and location within the area. Users survey results, again, reasonably positive results from the user survey. About 80% felt opening hours met their needs. 95% felt it easy to find a pharmacy open in the day, but about 50% found it easier in the evening, so it's a bit harder access in the evenings. 32% found it difficult, and similarly about half found it easier at weekends. 23% found it difficult. But generally people were satisfied with the service they were getting from pharmacies. It's about 76% satisfaction with the advice they were getting. But we did pick up a few comments around some of the pressures pharmacies are under, being able to access medicines, and also being able to use private rooms for some of the conversations rather than have to talk across the counter was a particular issue that came up. So in terms of the document, we are very much out to consultation on the draft. It's a 60-day statutory consultation. Very much welcome views from the board, either today or after the meeting. There is a survey form available to capture comments. We've still got the pharmacist and user survey open, so we are capturing more comments as they come through. And then in terms of the next steps, we do need to get a document agreed by the 1st of October, when is the statutory requirement to publish the P&A. So we will bring another draft and circulate it to the board members outside of the meeting process in September to welcome any sort of further comments and views on the final draft. And we might need to seek approval, a delegation for the chair in consultation with the chief officer, just to agree that we can submit it, and then come back to the board in October, where we could look to pick up any final comments and amendments to the document. So that's all I wanted to say in the introduction. There's a hell of a lot of detail in the reports. It's just the kind of structure that we have to follow. Happy to try and take any questions. And similarly, Hannah, who's on the call, has been involved in this analytical piece of work. I'm sure Hannah can try and pick up some of the detail if you've got any particular points. Thank you, Chair.
Thanks very much, Andy. I'm going to be quite strict because I'm really conscious that we've got the item 15 next that we need to. So Janet.
Yeah, it's just to say that I've received an email from Andy today and the consultation, public consultation is being extended to the 21st of August.
Thank you very much. So extended consultation. Any other comments from members? Mike.
Yeah, just to thank Andy and Hannah. If I was going to take board anywhere, I think it's the conclusions in chapter 16, page 31 of the report. And I think there is some interesting ones there just in terms of the perceptions of community pharmacy staff being the easiest healthcare workers for members of the public to access, and also recognising that pharmacies have extended their offers. So as well as the detail, I think there's some broad brush stuff in there that we probably need to consider as we go through the system that is Rutland in the place that is Rutland, as John was saying earlier, just to reflect on that, as well as the minutiae of which pharmacies are aware. So it's good stuff.
Thanks very much. What I will do then, so we're going to note the work undertaken to produce the draft P&A, which has been developed in line with the findings. We're going to comment on the draft P&A, which is now up for consultation. The consultation has been extended to the 21st of August. I would ask that members actually complete the consultation. That would be really helpful. And then we note that the further draft will be circulated to us prior to the 1st of October, detailing the outcome of the consultation and seeking approval of the final P&A. I'll propose. Is someone happy to second? John, and are we all in favour? Yep. Thank you. Thank you very much, Andy and Hannah.
Thank you, Chair.
I'm sure members, if they do have any questions, we can kind of catch up outside, and I apologise that I've had to hurry you along with my time management slipping, so apologies for that, but thank you both.
Thank you.
So next we're on item number 15, which is Rutland Memorial Hospital. We've got a health plan update, and this is being presented by Sarah.
So I'm going to keep this short and sweet given the time, but what you've got here is a combination of the health related actions that are in the health and wellbeing strategies development plan, and also some of the wider responsibilities of health that we've got, and how we would see that developing in Rutland. So there are about 4 or 5 key themes that run through the plan for Rutland, and most of which we've talked about today, to be fair. First of all is care closer to home. That involves obviously the work around the BCF and the integration of health and social care, but also the second point I'm going to come on to in a moment, which is around elective care, but also how do we develop the workforce within primary care to get that integration piece. The second area is about diagnostics and outpatients, both new and follow-up appointments, but also simple procedures. And how do we bring more of that closer and use Rutland Memorial to do that? There's a whole piece around primary care access, because we know that that's a key issue for Rutland in particular, as well as across the country, to be fair. I've touched on the integration agenda already, and then there's some underpinning areas around estates, digital and the cross-border work that sit across all of those things. So it sets out a relatively, what I believe is a comprehensive plan about how we see health services being delivered in Rutland. Obviously, this is a high level plan. There's a lot of work and a lot of detail that will go in behind it. A lot of the work is already underway, but I think it gives us a plan to then start to deliver on. So I'll stop there and take any questions.
Thank you very much, Jana. No? Oh, it looked like. Does anyone have any questions from the board? No? Go on, Mike. Don't
for the sake of
disappoint me.
making certain there is a question, because it is important. What's next then? So did you spell out the next steps? Apologies.
So I think there are steps within, I'll ask Deb to come in a minute because she's leading a lot of this, but there are steps within each area for us to take. So do you want to just?
So, and I think I touched on this a bit earlier. We are already well underway with quite a few of these plans. I would like a report back to the next board on our primary care sort of offer, and also our diagnostics and some of the elective services. One of the key enablers is around the estate, which we've talked about. So there's a strategic assessment of Rutland Memorial Hospital happening in the next couple of months, and also we've got somebody coming in to work with our primary care again to look at their clinical strategy as well as and their state strategy that comes out of that. So those are key pieces of work that we are progressing. I think it is helpful to say that Rutland Memorial is very much part of our healthcare plan, both for having an integrated health and social care offer, but also trying to deliver services closer to home. Resources are tight, as you know, but we have some plans that we are working with. Some are underpinned by the physical estate, but some plans that we're just progressing with that anyway in Rutland. So we've done some quite good progress with a potential opportunity around MRI, which I'm hoping to give firm response on in the next few weeks. But it's part of our the LLR strategy to increase local MRI provision. So we're looking at an area within Rutland that we're able to utilise for that. We've had initial talks with the charity around underpinning some of the setup costs. So I'm hoping that we're going to have some better good news on that in the next 6 to 8 weeks.
Thanks very much, Deb. Apologies to those on the call. There's some children just leaving the building who are so they're having we'll talk louder and then we won't be able, then we'll over talk them. Do we have any other comments? No. I would like to thank our health partners for this piece of work. I know it's been months in the offing. I know it's been challenging, but actually it is actually really appreciated by our community that Rutland Memorial is being kind of highlighted, that it is valued. It's particularly pleasing to hear around additional diagnostics such as the MRI. So we wait excitedly for any further news on that. So I think our next one is we're now going to receive a report from Angie, who is online, who's our interim head of Safe and Active Public Realm. She is going to report on our levelling up bid. I'm really sorry to say that we've only got a real couple of minutes. If you could just do a real brief outline for us, Angie, and then we can ask any quick questions. Apologies for the time.
Okay, so the report that's in front of you sets out the proposal to submit a bid to the Levelling Up Fund round 2, and that was considered by the Council's Cabinet on the 14th of June. So it's a joint bid with Melton Borough Council for about 15 million. You could have gone for 40, but as we're a tier 2 authority, that's the right level to go for. You could have 3 main centres within the bid. So Town Centre Regeneration in Oakham, Town Centre Regeneration in Melton, and an improved rural transport system are the 3 areas. And what's pertinent to the Health and Wellbeing Board is the Rutland Memorial Hospital is one of the sites proposed for a new health innovation centre, which will be Digitech, Meditech Centre, and that's based on there's quite an interesting set of papers of an evidence base that looks at the social and health benefits of that to Rutland in particular. in that we have a higher proportion, we're disproportionately high for the number of veterans, vulnerable older people, and also outcomes for women with a lower rate of healthy life expectancy, which has been falling since 2013. So what the bid will do, if we're successful, is enable the development of that centre, which will improve treatment technologies, pharmaceuticals. It will provide access to high skills jobs and will indeed attract candidates as well, because we know recruitment of high calibre staff is an issue, and that will hopefully help the Memorial Hospital and the GP surgery just on the same, on the back of the site. So the deadline for the submission is the 6th of July. But given the changes this week in government, it's perhaps not surprising that that portal is not yet open, and there'll be a fortnight for the submission of that. So the Cabinet is supporting the bid, but if we're successful, acceptance will be a matter for full council, given the scale of the ask, as I said, about 12 to 15 million. So that's it really. I'm happy to take any questions.
Thank you very much. Do we have any questions? Nope. I think we'll move quickly on. Thank you very much. So we need to note the submission of the joint application by RCC and Melton Borough Council for the round 2 of the Levelling Up funding in line with the council's constitution financial procedure rules. And we're noting that the joint application was submitted on the basis that a detailed discussion regarding funding, including any ongoing financial implications, would be required should the council be successful in securing the bid. Any discussions would result in a full council discussion to accept or reject funding offered. So I'll propose that. If I could have a second, thank you, Janet's going with that. And then if everyone's in favour, thank you very much. Now we're just pausing just so I can do some housekeeping around governance because we're at 5 o'clock. Right, colleagues, I'm aware that this has been a mammoth meeting and is still going on. I'm also know that we've got Sarah here who was doing the health inequalities. I will ask the board actually what you would like to do. We could defer that to October, or we could and then we would just do our last things. Or Sarah, do you want to come in?
So I think for the majority of it can be noted because it's just describing the core 20+5 concept that we're working, we're using to around health inequalities. However, I would say one thing, and we can work on this outside. Mike will understand what I'm saying in a moment. We are looking at being having some funding available to support particularly the plus population. So each area choose a plus population and then start to develop some interventions that would reduce the inequalities gap. So at some point, the health and wellbeing board would need to agree or support that plus population. But I think it probably needs some officer development outside with options and then brought back. Do you agree, Mike?
Yeah, and I'm also thinking it ties in with the health and equalities JSNA chapter, doesn't it? So I mean, I think you're right. We can note what we're about in terms of the paper, and then the work is looking at what we've got in Rutland, what we then utilise the money for, and then come back here.
Do we need to just keep it again? Keeping housekeeping. I am desperate that October meeting is online. Do we need to just pass just for our governance housekeeping? Is it worth us taking a vote whether we want to defer any decisions to the chair and the director of public health? Would that be helpful?
I think that would be helpful
if we delegate it, and then would that be helpful? And then we'll have the discussion in October. What that just means is housekeeping wise, we don't need to be in person. We can vote in principle online, and then governance wise. So it's not about removing it from the board. It's about just getting the housekeeping in order, governance style. Would you be happy with that as well? Is that something we could do? We did need to close at 5, right? Okay, so I will propose that we've received the Yeah, I will propose that we just do some time. We'll receive the report and that we'll delegate to the chair of Health and Wellbeing Board and the director of public health the formal decision that we will make in principle via our October meeting. So I'll propose, do I have a seconder on that? Mike will second. Is the board in favour of doing that? Thank you. Did you understand what you were voting for? Did I make it clear? Thank you. Sorry, Deborah.
Could I add in the delegation, the decision also to the place lead?
Of course.
So the three.
The three. So
yeah.
James Burden, Dr. James Burden
Thank
as
you.
well. So sorry, can we have that in?
Presuming he accepts his.
Yeah.
Well, he's accepted it's just the vice chair, isn't it? But he's got to accept. So we're over time. I apologise, everyone. The forward plan and the annual work plan. If members are happy, I'll take that. I'll liaise offline with that about. But I noted, was it Deborah or Janet that I asked you to hold that thought until the further items. So if I have a conversation with you out and then we can include and then we don't have any urgent business because oh no, we do have some urgent business. Sorry, we do. I just wanted to take an opportunity to thank Sandra Taylor, who this is actually her last Health and Wellbeing Board, and she's passing the baton on. She is deputising to another role, and so I myself as chair will sorely miss her. I cannot state how much of a help she is to me in this role, and actually she will be a huge act to follow. I think she's coming over to the ICS, so it is definitely their gain and my loss. We will, obviously the plan has been her baby and she has worked so hard on it. So I would like to acknowledge in the minutes our thanks for that and wish her luck. And we will see her again because she will be around, but my right arm is missing from now on. Thank you very much. I will close the meeting. Apologies, we're so late. It is 5 minutes past 5. Thank you.